sharing. We encourage each one of you to actively participate in discussions, share your experiences, and engage with your fellow attendees. Your insights, expertise, and unique perspectives are invaluable in our collective pursuit of excellence in emergency care. Now, I would like to call upon our Honorable CEO, Sir, Mr. Pradipta Swain, to please come on stage and welcome the honorable guests.
Good morning, ladies and gentlemen. Thank you, Isani. Respected Chairperson WBCREC, Director in charge DSP, Durgapur Steel Plant and ISCO Steel Plant, Quality Man of India, Dr. Gyani, Honorable members of the Commission, Chairman, Sir, the Mission Hospital, Managing Director, Sir, the Mission Hospital, and all other dignitaries and my colleagues and friends. A very warm welcome to each one of you at this momentous emergency re-engineering conference. It is truly an honor and privilege to stand before this gathering of great luminaries, doctors, sisters, and brothers. In times of crisis like one we find ourselves today, it is imperative that we come together to exchange ideas, innovations, and expertise. Our mission as healthcare professionals is to ensure the well-being and health of our communities. Our institution has taken visionary step to organize this conference, bringing us all together to re-engineer our approach to emergency healthcare. Over the course of this conference, we will delve into critical discussions, share best practices, and explore innovation solutions that can redefine emergency healthcare for the better. Therefore, I encourage each of you to engage actively in the session, network with your peers, and leave no stone unturned in our collective pursuit of excellence in emergency healthcare. Once again, I extend my heartfelt welcome to this exceptional gathering. Together, let us embark on this journey of re-engineering emergency healthcare, knowing that our efforts today will shape a healthier, safer tomorrow for all. Thank you for being part of conference, taking out the time from your busy schedule. Thank you all.
Now I would like to call upon stage our revered guests of honor and take the opportunity to felicitate them to express our gratitude for their august presence. Honorable Justice Ashim Banerjee, sir, graduated from Scottish Church College, Kolkata in 1972, enrolled as advocate with the West Bengal Bar Council, November 1976. He became the judge of Calcutta High Court on 15 September 2000. Currently, chairperson of West Bengal Clinical Establishment Regulatory Commission, he has contributed immensely to the commission, especially during the COVID times. Sir, it's an honor and an absolute privilege to have you here today to partake in the conference. Can we please have you on stage? Lal sir, our President HR, I would request to kindly felicitate Ashim Banerjee, sir. Next, Shri Brijendra Pratap Singh, sir, B.Tech in Mining Machinery from Indian School of Mines, Dhanbad. Shri B.P. Singh joined SAIL at the iron ore mine of Vilai Steel Plant in 1989. With a rich experience spanning over 32 years and continuing the trend of excellence in performance, Shri B.P. Singh is a director in charge of DSP and ISP plants. Welcome, sir. Dr. Giridhar Gyani, the quality man of India, as has been mentioned by our CEO, sir, Director General at Association of Healthcare Providers, with hands-on experience in administration, teaching, training, research and development, quality management, accreditation, and standardization. He has served as Secretary General at Quality Council of India for more than 8 years and has been instrumental in establishing and operating national accreditation structure for conformity assessment bodies. Please welcome on stage Dr. Giridhar Gyani. Shri Shutirtha Bhattacharya, sir, was the Chairman and Managing Director of Coal India Limited. Prior to this, he was a Chairman Managing Director of Singareni Collieries Company Limited. He has advocated coal pollution mitigation technology to reduce harmful environmental impacts while still seeking to double coal production. A physics graduate from Presidency College, Kolkata, and an IAS officer of 1985 batch from Telangana cadre. Okay. Son of the soil from Durgapur. Professor Dr. Shukumar Mukherjee. Dr. Shukumar Mukherjee is an internal medicine specialist practicing in Kolkata with over 45 years of experience. He has been awarded the Lifetime Bongo Vibhushan Award by the Government of West Bengal in the year 2014, Jamini Anand Lifetime Achievement Award as medical teacher in 2011. He has also been awarded the Dhanantwari Award in 2008. He has been awarded the WHO Fellowship on Clinical Management of AIDS in Sydney and Melbourne, Australia in 1989. It's an absolute honor for me to welcome you on stage, sir. Professor Dr. Makhonlal Shaha, Professor and HOD, Department of General Surgery in IPGMER and SSKM Hospital, Kolkata, and a stalwart in the field of advanced laparoscopic surgery and oncosurgery, and on retirement has been engaged as expert in surgery unit of MBAR, Bangur SSH. In his own words, he believes in healthcare that is based on a personal commitment to meet patient needs with compassion and care. Requesting you to please have a seat, sir. Shri Arshad Hassan Varsi, sir, WBCA's and Secretary, West Bengal Clinical Establishment Regulatory Commission, and Additional Secretary of the Department in the post of Special Secretary, Health and Family Welfare Department since 2022. Welcome, sir. Dr. Moitri Banerjee, ma'am, Honorable Member of WBCERC. She has been the head of Department of Lab Sciences in SSKM Hospital and now helping Kolkata Municipal Corporation to set up lab in Khidrpur Hospital. We are privileged to have you amongst us today, ma'am. Ms. Madhavi Das, ma'am, Honorable Member of WBCERC. She's a Director Nursing with Sister Nivedita University and earlier Joint Director Nursing with Government of West Bengal Health and Family Welfare Department. Ma'am, thank you so much for finding out time to be a part of this seminar. Dr. Satyajit Bose, sir, our beloved Honorable Chairman, sir, he needs no introduction, not only in the field of cardiac surgery, but also in the sphere of healthcare entrepreneurship. An eminent cardiothoracic and vascular surgeon, practicing for more than 2.5 decades and performed more than 35,000 complex heart surgeries. He has pioneered total arterial CABG in Eastern India since 1999 on a beating heart. It's an absolute privilege for me, sir, to welcome you on stage. Shri Tarun Bhattacharya, sir, our Honorable Managing Director, he's known for his long association with the education sector in Durgapur. He's also founder member and secretary of a leading engineering management and pharmacy college. He's renowned for his administrative acumen. With his compassion and warm-hearted leadership, he plays a vital role providing guidance to all team members and helps shape our policies for excellence and future growth. Professor Dr. Suresh David, the first Indian physician to be formally trained in emergency medicine. Dr. David pioneered the practice of emergency medicine in India and is credited with founding the Department of Emergency Medicine at Christian Medical College, Vellore. He is the first person to hold the position of a professor in the discipline of emergency medicine in India. He is consultant of the World Health Organization for Emergency Medicine for Southeast Asia and is a faculty of WHO USAID programs on disaster medicine. Professor Dr. Sanjeev Bhoi. Dr. Bhoi has received the prestigious Michael Moles Fellowship from the World Association of Disaster and Emergency Medicine at Victoria, Canada in 2009 and served for 2 years as one of the board of directors of ADAM in May 2013. He has created AIMS Disaster Ultrasound Program and has been training doctors, nurses, and paramedics. These courses are running across the country as well as in Nepal, Sri Lanka, Iran, UK, and USA. Thank you for being with us, sir, today. Dr. Subrata Das, sir, winner of Padma Shri for his work on highway trauma care, works at the crossroads of emergency medical services, public health, public safety, trauma care, and industrial medicine. He is the only Indian to be honored with the Asian EMS Lifetime Achievement Award by the Asian EMS Council in 2015. An Ashoka Fellow, he is founding member of Asian Association for EMS. Welcome, sir. Dr. Sanjay S. Pawar. Sorry, he has still not reached. We will honor him later. Professor Dr. Raghunath Mishra. Okay. Dr. Priyansha Chatterjee. Professor Dr. Shudipa Das. Dr. Joyantu Das. MBBS FMAS from Delhi, specialized in GI, general surgery and vascular surgery, and currently consultant general and vascular surgeon with AMRI Hospital, Kolkata. Already. Dr. Kishan Goel, passed out from Kathmandu University in 2014, MD Emergency Medicine from JIPMER, postdoctoral fellowship in critical care medicine from AIIMS, Bhubaneswar, currently working as assistant professor in emergency medicine, SSKM Hospital. Professor Dr. Bhabatosh Biswas, eminent pediatric cardiac and vascular surgeon, consulting in Kolkata for over 44 years, former VC of the West Bengal University of Health Sciences and former Vice President, National Board of Examinations, New Delhi. He is currently the National President of AHPI. Thank you so much, Lal sir. Now may I please request Shri BP Singh sir, DSP DIC, to kindly come address the gathering.
Dr. Satyajit Bose, Chairman, Mission Hospitals, and all other dignitaries on the dais, all the dignitaries of the dais, all the doctors, paramedics, nurses, and everyone present here. First of all, a very good morning to all of you. Mission Hospital, Durgapur, one of the premier institutions not only in the area Durgapur, West Bengal, and also throughout the country. One of the best hospitals, one of the best medical facilities provided by the Mission Hospitals. The residents of Durgapur and nearby areas are lucky to have such a wonderful facility here. They are not only providing the facilities in terms of the health care, but time and again, the Mission Hospital is doing these kinds of conferences and events to reinvent the things. Today, the topic, re-engineering the emergency care. The importance of emergency care, we all know, may it be the critical illness, may it be the accidents. It's so important to save the life of the people. And the emergency care is coming up very fast in the India. Already, as I was discussing with Dr. Bose, that it has come in the other countries 30, 40 years back. Now, the importance of emergency care, we all know. The event, the conference organized will go a long way in bringing in the new things and bringing the new technology, new fields of re-engineering the emergency care. My best wishes for the success of the conference. Thank you very much.
Thank you so much, sir, for addressing the gathering here. May I now request Shri Vasi sir to please address the August gathering.
Honorable Chairperson WBCRC, honorable members of the commission on the dais, honorable chairman, Mission Hospital, director DPS, MD, Mission Hospital, and founder of affordable healthcare, private healthcare, Girdhar Gyani ji, and the honorable audience present here, and the dignitaries of the dais. It is a matter of great pleasure that Mission Hospital has organized a workshop on emergency care today. The Commission has been encouraging such workshop in view of the fact that there are some areas which is to be taken care of, especially in Kolkata. We have held such workshops. Even in Durgapur, we had held such workshop. We had held it in Siliguri as well, and the different topics have been taken up, like critical care, infection control, management by the people, and billing issues, and admission and discharge issues. All the big hospitals of Kolkata, Durgapur, and Siliguri were involved, like Apollo, R.N. Tagore, CMRI, all these hospitals. They had, even in Durgapur, we also had such a workshop. The purpose of it is to ensure that the areas which need to be strengthened, which need to be taken special care of, that should be taken in right earnest. And all these areas from where we get complaints, the Commission has dual responsibility. One is to hear the complaints and dispose them off in a very scientific and satisfying manner. And secondly, it has the responsibility to regulate the charges, to regulate so that the entire private health sector is affordable and reachable to the common man. So these are the twofold responsibilities of the Commission. In first area, we have achieved the optimum level. Till date, we have disposed of around 2,000 complaints, and we have given around 7 crore rupees in compensation or refund. So that is a great thing. In last 4 years almost, we have been able to give this amount, 7 crores, to the service recipients. But that is not enough. We want to see that there is no complaint. We want to see, the Commission wants to see that every patient is well taken care of. That is the objective. And the objective of such organization is to ensure that the areas which appear to be neglected or which appear to be not so well managed, that has to be discussed, and there has to be brainstorming so that these areas, the complaints in these areas do not come. And we have noticed that it has its impact also, because of the fact that we have noticed that even the cases of sepsis, in the cases of infections and death due to infection in hospital, that has come down. So there are many issues. So we are really very thankful to Mission Hospital that they have organized it, and we do hope that today's brainstorming, there are very distinguished academics. They will be giving their lectures, and that will help the people involved in health sector to come up to the expectation. So with these expectations and with these wishes, I wish that this workshop is very much useful and fruitful. Thank you very much.
May I now request Professor Dr. Shukumar Mukherjee to kindly come on stage and address the film.
Good morning. Justice Banerjee, Dr. Satyajit Bose, Dr. Agamani, and all the dignitaries in the dais. It's a great pleasure to be here in the Mission Hospital for on behalf of Commission, but I'm a part of the doctor's profession. I think if you remember, the national slogan today is perform, reform, transform. As an end result, Dr. Satyajit Bose has coined the title of this program, Re-Engineering of Critical Care. Re-engineering not for the knowledge sake, but re-engineering for the patient's sake as well. That is very important today. Today, all over India, 70% of the patients are being handled by the private hospital, and the public hospital residual 30%. Obviously, you have got a large mass of people, of 140 million of Indian population, handling the patients by the private hospital. So it is our duty to make the private hospital worthy of the situation where the people have got the access, can afford, and also can come with some amount of respect. I think today's slogan is affordable ICU, and that is the most important global term, and on behalf of the Commission, we are trying to foster the affordable ICU with the maintenance of quality, and that is the big jargon. But whether it is to be made with the collaboration of the people as well as the doctors at large, that is a moot point. And all the meetings we have been attending all over the West Bengal are nothing but the same purpose, affordable ICU for the benefit of the people of India. And you are the pioneers. And I know Satyajit for a long, long time is a dynamic, vibrant surgeon. And he has come for B.A. Birla to Mission Hospital long time back when we were in the CMRI. And I'm sure Satyajit will make a real penetrance, affordable ICU for the people of the district of Durgapur, Bankura. I worked in Bankura for at least 6 years, and I know Durgapur in 1970s to 1976. And that Durgapur is no more, more vibrant, more developed, more updated, more populous, and more improvement are visible in Durgapur. So I'm sure in this situation, we must work together to make it worthy of the people with the maintenance of quality. That is my only wish, which I can see in my lifetime. Thank you again for your kind attention.
Thank you so much, sir, for giving us an insight into the emergency care. I will now request Shri Shudita Bhattacharya, sir, to kindly address the august presence.
Good morning, everybody. Honorable Chairperson of our Commission, Justice Ashim Banerjee, Honorable Members, our Director in charge of Durgapur Steel Plant and ISCO of the SAIL, the legend Dr. Agamani, my classmate Tarun, who is sitting here. And of course, if I may call Dr. Satyajit, because I come from Andhra cadre, the Pratap Reddy of Durgapur, I think that will also be a kind of tribute that will be paid. It's a very interesting day. The Mission Hospital is launching a mission to re-engineer critical care. The critical care is a subject with occupational hazard, the golden hour concept, the mobility concept, the transportation concept, emergency drug concept. All these are considered to be a kind of multivariate analysis in the model of critical care. I'm sure I was a part of the committee in the state of Andhra Pradesh which went into the question of critical care, but in a very little bit bigger city of Vizag, because huge number of industries and others were involved. As I said, it does not really depend upon the hospital, but that the Mission Hospital has launched it reflects that they have come into the outreach mode. It is the big institutes, as the guru of doctors in West Bengal, Professor Sukumar Mukherjee just said that increasingly insurance-backed treatment and huge incidence of private sector in the facilitating treatment of the Indians is an established phenomenon. The public health practice will be invested by the government. The medical care will be increasingly, we are not exactly going on the Scandinavian route, but maybe we are bringing in the US route with the touch of Obamacare. I mean, I'm saying that's the kind of model that is being building up in the state. The Swasthya Sathi program is there. In some other states, insurance program runs. Aragyasri was one of the programs which was launched in 2006. The point at issue is all these programs also bring in government investment, inter alia public-private sector into the healthcare business. And one of the most fundamental areas in healthcare is the area that today we are dealing with. We are dealing with emergency, we are dealing with critical care, we are dealing with capacity development. There are huge amount of expertise available today under the roof. And I'm happy that doctor has come from CMC Vellore, and please convey my regards to Dr. Manman Chandi. And it's a good day if we can convert this into a mission. And there is a session, a very interesting session, on how the technology and artificial intelligence, use of emerging technology, which the entire world is using, how it will re-engineer the critical care. I think there is a session around 3 o'clock or 3:30. It will be very interesting to really learn from that kind of session. You might have seen, all of you may be knowing much before than me, the UK Health Service in the cancer treatment has introduced intramuscular cancer injections, which will reduce the treatment without compromising the quality. The goal is deal in more quantity, but with enhanced quality. It's a challenge, but if the going is tough, the tough will have to get going. So I'm sure this seminar will put up solutions. We'll look at capacity building issues. We'll also send, perhaps the commission has been sending under the leadership of our chairperson, the capacity building in the peripheral areas. Because if we really look at critical care has to be looked at in the closest vicinity of the patient. As I repeatedly said, paramedical is one area training of paramedical staff in one area is a very critical experiment. I mean, in once upon a time, 1970s, I am saying, a good doctor would recall, in Maharashtra, Dr. Arole experiment used to be there, Raja Arole experiment used to be there. So that kind of experimentation here has to take place. Across the world, it's the paramedic which deals with emergencies. So we'll have to enrich them. We'll have to give them confidence. Mere investment in capital infrastructure will not be good enough. Biggest capital in clinical care is the doctor, his staff, his accompanying personnel. Let us invest in that capital, not only by giving training, but by instilling trust in them, by ensuring that no capital infrastructure of the conventional kind remains unutilized because we have failed to instill that iota of confidence. Let us be confident today that we will take up all collectively, all let us pledge that at least we'll dedicate to this cause with all the might that is at our command. And in the scale of treatment, let the re-engineering start and let that bring about public good, let that bring about more affordability, let that bring about the well-being of the people who may not be financially sound. Let it be of the people and for the people. Then only the holding of such re-engineering workshop, which is a very holy cause, will meet its success. And amen to that. Thank you.
Thank you so much, sir, for giving us an insight into the role that government and private sectors can take in enhancing emergency care. Next, may I please request our Honorable Chairman, sir, Dr. Satyajit Bose, to kindly address the August gathering.
Good morning, everybody. Honorable Justice Ashim Banerjee, sir, it's a great pleasure to have you with us. Mr. Brijendra Pratap Singh, the director in charge of both the steel plants in the vicinity, Dr. Girdhar Gyani, my friend for several years, Dr. Shutirtho Bhattacharya, my sir, Dr. Shukman Mukherjee. One word about Shukman, Professor Sir, is that I told, Sir, কবে লাস্ট দেখা হয়েছিল বলুন তো? কেন? 5-6 বছর আগে বীরভূমে কাঞ্চনের ওখানে we met you. I had forgotten. So we must all collectively understand how he keeps this memory at the age of 88 years. What elixir, what amrit he is taking. And Professor Makhunlal Saha, Sri Arshad Hassan Varsi, Dr. Maitri Banerjee, Dr. Madhavi Das, and my colleague in crime, Tarun Bhattacharya. So basically, it's a great thing to have all of you with us and to participate in this great gathering in which you are dreaming of re-engineering emergency care. So essentially, way back in the 2005, the entire healthcare industry or service, super specialty healthcare service, was centered around Calcutta. We had everything that happened was in Calcutta, in Eastern India, or for West Bengal. But when it came to any person who was having any critical illness, would have to travel to Kolkata to get the treatment or perish at their own hometown. Or even for a simple thing like, dangerous things like snake bite, for even a dog bite, or maybe a heart attack, you either perish or you run to Calcutta. So, and therefore, there was a loss of confidence of people in the districts who formed the majority of the population in the state. They were all traveling down south. So basically, as part of the blue ocean strategy, red ocean is you go wherever all the shops are there. So as a part of the blue ocean strategy, we decided to explore the unexplored, and we decided, because I was born in Durgapur, Tarun Babu is another, to make something big in this place, because a small or a medium-sized hospital would make no sense. So we embarked upon our journey in 2005, and the dreams turned into reality in 2008 of 2nd of April. We started with 250 beds, and now, as you can see, we are almost 600 beds, and we are NABH accredited, fifth edition lately, and we are NABH accredited from 2013. So this is a long journey, and initially people were traveling all around, but the fact remains now, ladies and gentlemen and respected guests, is that there is a reverse drainage. Even doctors, big industrialists, and normal people are coming from Kolkata to get their surgeries down in our hospital, and people from adjoining states and countries like Sikkim, Bhutan, and Myanmar, and even from faraway places like Pakistan, from Ghana, Nigeria, and Iraq, and also Afghanistan, people do come here for their treatment in our hospital. So we have actually put Durgapur in the world map by this, setting up this super specialty hospital. And we do a lot of, nothing is complete if there is no contribution to society, because we all come from society. So we do a lot of service to society. We do have we participate in all the government beneficiary processes, like, the thing that Mr. Warshi was talking about. And we also, there is a lot of give back. We participate with programs for Rotary and Alliance and all that, so that we also cater to heart surgery for children at a very subsidized or sometimes free to the end user. And we've been doing this for several years. So our social footprints and emotional footprints with the people of West Bengal are very, very strong. And we recently also started an eye hospital about a couple of years back, and that eye hospital has also got an NABH accreditation thanks to the generous help of the Mission Hospital quality team. And we are very soon embarking. We have acquired 10 acres of land in the vicinity, where we are starting with a 600-bedded cancer hospital, state-of-the-art, along with transplant facilities, solid organ transplant facilities. So this is, in short, a little plan. And we are committed to decentralized healthcare, which have been a major drawback for people of West Bengal. And at the same time, we want to reinvent ourselves, bring about better quality and participation of great luminaries, as all of you are here. And we want to take this. And to take this step forward as leaders, our job is to create more leaders, so that we stay in the backyard, and we have a great team with us. Our CEO, Mr. Pradipta Swai, our President of HR, Mr. Ramesh Lal, Dr. Partopal, who is our Medical Director, and also Ishani, our Vice President of Operations, and so many other people, and all the consultants. We have nearly 160 full-time consultants who are catering to every nick and call for all the people of this region and outside. And thank you at the end for coming and making this program a great success, and I hope you're going to really enjoy today. And sir, thank you very much for being with us today. And as all of you know, that I'm still a practicing cardiac surgeon, and I've got programs lined up in the operating room today. So after the first session, I will have to leave, and I'll rejoin you again. But during the conference, I will request Dr. Partopal to please take turns to take our luminaries to visit our hospital for a short while. Thank you very much, sir.
Thank you so much, sir, for your words of wisdom and giving us an understanding on the increasing need of emergency care and the role of leaders in the industry. May I now request Justice Ashim Banerjee, sir, to kindly address the gathering. Sir.
Very warm good morning to all of you. And a special thanks to Dr. Satyajit Basu. The reason I would be divulging within a short while. Way back, maybe a year or so, when the CERC was holding workshop on various burning issues that came to light while redressing grievance of the patients. We started touring the districts. And one day we reached the destination of Durgapur. So before that, the single point contract Dr. Parthopal, I thought Mission Hospital first, and I gave them an opportunity. Then Dr. Pal said, sir, kindly give me the opportunity, but we do not have adequate space to do it in the hospital itself. So I said, very well, next time, because at this time we are moving from one hospital to the other. So today the dream comes true. Calcutta, as Dr. Bose has said, being the capital of the state, and people with ailments, even on the other day, they used to approach private health sector as well as government health sector at Calcutta. And many a times golden hour is lost in transition. In course of time, Durgapur and Shiliguri has made it by putting infrastructure that in some cases even better than Calcutta. Give a wide applaud for these hospitals at Durgapur and Shiliguri. And when I say, I mean it. And there is, as I said, a special thanks to Dr. Bose. Day before yesterday, I had interaction, maybe hot exchange of words with one of the renowned super specialty, uni-specialty hospital. The problem is that Calcutta, I'm talking about private health sector, Calcutta, 3 important ailments, cardiac, neuro and onco, 3 hospitals, BM Birla, Institute of Neuroscience and Tata Medical Center. During COVID, a patient was undergoing treatment in INK, having Bullenberry syndrome, a rare disease possibly. And luck would have it, the patient got infected with COVID. The hospital says, we are uni-specialty, take your patient back. And this was the second wave, mind that. It was not possible to shift the patient, and he was critically ill, undergoing treatment at ICU. I had tremendous pressure from many corners to have the patient shifted. I said no. And I am grateful to those doctors. I still remember Dr. Vibhuti Shaha. Those government doctors, they went to INK, treated the patient, and that patient today, he is doing his, running his normal life. We are pride, TMC is really a pride of Bengal, because in oncology, Tata Medical Center is a name, not only in Calcutta, not only in West Bengal, throughout the country, and catering the need of the entire eastern sector, including the neighboring countries also. Now, day before yesterday, as I say, a patient was seen by the consultant having some problem in colon. I do not wish to name a very famous oncosurgeon, examined and advised surgery to be done, but the patient had cardiac ailment. Now, these unispeciality hospital, they would say that if the patient after surgery have some cardiac problem, then we do not have infrastructure. This I put it and I took it up with TMC, and yesterday before coming here, the director called me up and said, "Sir, you have opened our eyes. We are doing." I said, "You do, at least you give the initial treatment, and might be at a stage when the patient would need precision care, special care, then patient could be shifted. But why a patient since he has a cardiac ailment, he would be deprived of a surgery from the best hospital, one of the best hospital in oncosurgery in India?" I thank Dr. Bose. Being a cardiothoracic surgeon, he has not traveled that path. He has put up this multi-speciality hospital, and I come to know today having 600 beds at Durgapur. Thank you, Dr. Bose. Now, coming to the issue which you would be discussing today. Yesterday, while coming to Durgapur, I understand that the policy makers, few years before, they decided, and very rightly decided, that emergency care, emergency medicine, emergency treatment, that should be the basic need. And there should be a curriculum for that. Now I understand possibly they are rethinking and they are changing it to super speciality. I am not a medical person. I do not know how this basic need could be transferred into super speciality. I do not know. I would just share you 5 incidents. Incident number 1, it was in 80s possibly. Our the then Chief Justice of India, Honorable Justice Shobboshachi Mukherjee, he was on vacation abroad with his wife and only daughter, had cardiac problem abroad. He was taken to the hospital, and there had been technical problem. I can't say I was not there, but whatever we have, the information, there had been technical problem, and that time mobile phones were not there, where within a second you can contact any part of the world. The Indian High Commission delayed in reaching the hospital, and the people would say, Dr. Justice Mukherjee breathed his last on the trolley. It's an unfortunate thing. I do not know, I am not a doctor. Even after treatment, whether he could survive or not, that's a different thing. But he did not get the basic treatment. Abroad, not in our country. Incident 2. Very recently, maybe a few years back, maybe 2018 possibly, a young boy, being a proud father of a twin, 7 days old, he was proceeding to Sector 5 Salt Lake, IT sector employee, using Ma flyover. Motor car dashed him. He fell down from the motorbike and he was bleeding profusely. Fortunately, there was no other serious ailment except orthopedic problems and the profuse bleeding. Ill-fated boy did not have good Samaritan because everyone was busy. It was a busy working hours. Everyone was rushing towards their workplace. There was delay in reaching the hospital. The incident happened at about 10:30 in the morning, and mobile was there. The family was informed. They immediately rushed. From the local hospital, they took it to a very, very renowned hospital in the southern part of the city. The records revealed the patient direly needed blood transfusion. That was ultimately given at 11:04, not AM, PM. And we lost that boy. These are the two incidents that would really be eye-opener for us, that emergency care should be the basic necessity in the golden hour. The first one was ailment and the second one is an accident. Now then I come to the other three incidents. A young girl conceived, very downtrodden family, close to Sundarban, remote place of 24 Parganas South. She had problems that could be diagnosed by her gynecologist in the local hospital, and the patient was cautioned that you need special care and in a higher setup. That girl got herself registered in RG Medical College in North Calcutta, a place which would be around 50 to 60 kilometers away from her house. On a particular day, it was before COVID, possibly 2019. On a particular day, in the night, she became critically ill, and they could arrange for a small, might be an auto or something, I do not know. They started for Arjikor, could not reach. Before that, when they were crossing airport, the patient became too critical. And the nearby hospital was Charnock City. What they did not know it was a corporate hospital. The husband, what he did, he stopped the vehicle in front of Charnock and just rushed to the hospital. It was 2 o'clock possibly in the night, and said, please come out and save my wife. Only this he could say. On duty was a young boy who has just got his certificate in anesthesia, and a young girl possibly completed her MBBS, working as RMO. They came out and they could not take the patient within the hospital. The delivery was done in the car. Then the patient, the mother and child, they were taken inside. They have given the basic treatment. They got them admitted. Did not know what their boss would say in the morning, because it's a private hospital. They did not think that. But ultimately the family, they scared. They know that in the early in the morning they would demand for money. They do not have money. They just took the girl and the child to Ajikar hospital, and the family was saved. Incident 2. Again Ma flyover. Again IT sector boy moving on a motorbike, having a pillion rider, a lady, young girl, and the motor car dashed. The girl fell down, the boy fell down, but boy did not have much injury. But the girl was very critical, because there might not be too much injury, but the situation, the girl became traumatized and collapsed. And the entire fleet of cars behind that, they halted for a minute. What is going on? Two doctors, they were approaching, one attached to Apollo and the other one MRI Salt Lake. The Apollo doctor, he was driving, and the MRI Salt Lake, he had a chauffeur. And they just came out of the car and wanted to know what has happened. They saw the girl just on the floor, on the road. What they did, they took the girl in the lab and in the car, got the boy in the front seat, the driver, the doctor, the Apollo doctor started driving, and the MRI doctor started mouth-to-mouth respiration till the nearest hospital is reached. It was MRI Salt Lake. And the patient could be saved. Ultimately, the need of the hour, emergency treatment has been given. Then the patient was shifted to INK to exclude the neuro problem, anything. But after some days, the girl was released. The third incident just happened last week. A child was possibly, I do not know from which city, he was traveling to Bangalore for some surgery, and the boy became critically ill in the flight. And it came out in the newspaper, 5 doctors attached to AIMS, they were in the flight. They saved the child at that moment, and the child safely landed at Bangalore. taken to the hospital and the surgery was done. So these the three incidents, the emergency care at the golden hour, be it ailment, be it accident, be it trauma, whatever might be, is really the basic necessity. And every hospital must have a proper trauma care center in their own way. I would not mean that a trauma care center like attached to SSKM or in Delhi AIMS or trauma care center, but at least some facility so that the need of the hour can be taken care of. And I would be failing in my duty if I do not share one of the incidents. A young boy, maybe 13, 14 years, again, do not have any means. The officer in charge, Shantiniketan police station, called me and said, sir, this boy had a problem in what Dr. Shaha, you have said, what is it is? ASG or BSG. That's a hole in the heart, possibly. I just contacted Dr. Pal and sent the boy to mission, and he is now hale and hearty, courtesy Dr. Satyajit Bose. Thank you all.
Thank you so much, Justice Ashim Banerjee, sir, for giving us the wonderful insight into providing emergency care within the golden hour and the importance of delivering excellence with empathy. I now request our honorable guests to kindly light the lamp and initiate the conference. Professor Dr. Bhabatosh Vishwash, can you please also come on stage? Professor Dr. Suresh David, can we please have you on stage? Professor Dr. Sanjeev Bhoi, can we please have you on stage, sir?
वीर है गौरा तेरा लाडला गणेश, वीर है गौरा तेरा लाडला गणेश, वीर है गौरा तेरा लाडला गणेश, वीर है गौरा तेरा लाडला गणेश। माता है तू जिसकी,
So we just have one more thing, sir. Please bear with us. Requesting our medical director, Dr. Parthopal, to please initiate the release of the emergency pocketbook. Dr. Pal. There is a standee outside with the QR code of this book. If anybody wants, you can scan the QR code and get the soft copy of this emergency pocketbook. Thank you so much, our honorable guest of honors, for initiating and inaugurating the program. In the face of unforeseen challenges, emergencies demand immediate and effective responses. They test our resilience, our ingenuity, and our ability to adapt swiftly. Today, we come together as a community of dedicated healthcare professionals, researchers, policymakers, and industry experts to redefine and revolutionize the way we approach emergency care. I now request Dr. Tirtho Mukherjee, Head of the Department, Emergency Department, the Mission Hospital, along with his team, to present a simulation on disaster preparedness and polytrauma. Dr. Tirtho and team, welcome on stage.
কোনটা এটা কি হলো রে ঠিক আছে
While the stage is getting ready, may I request Dr. Giridhar Gyani, sir, to please come on stage and speak about developing safety culture. So.
Okay. Thank you very much. I think we are running 25 minutes late. And the kind of schedule which I am seeing, it is all crowded. So many experts are going to speak. So I'll try to cut down my own talk. But before that, let me tell you, Today I was supposed to be speaking at an international conference in Mumbai on the digital health. But the way Satyajit Bose called me that you have to come here. Now you can believe that that is an international conference और ये दुर्गापुर में हो रहा है. But the person, the pull which he has in him, charismatic personality, I could not say no. I told those people that I am going to Durgapur. So I am here on the, request of Satyajit, and in fact, I can tell you, I know him for now more than 7 years. The kind of, very rare few people are there who are clinician par excellence and entrepreneur par excellence, 2 in 1. So thank you, Dr. Satyajit, for making Durgapur. Okay, now let me, okay. So my talk is here. ये इसको फुल नहीं हो रहा. Okay, fine. ISRO is nowadays in a great news. But HPI, our own association, when Mr. Kiran Kumar was the chairman of ISRO, we established 2 teams of clinicians, one from emergency department and one from critical care. These 2 teams worked with the ISRO team for 6 months to get the best practices of the ISRO and transfer into medicine department of emergency and department of critical care. And these 2 guidelines are now available, and I think I will try to see that how the guideline on emergency can be distributed among all the delegates who are attending this program. And third thing which I want to tell you is that when I was developing NABH, the advice from Australian accreditation body with whom we were working was very simple, that आपको hospital अगर देखना है, कुछ मत देखो, just 2 department देखो, emergency and critical care, and you can grant them the accreditation. So that is the kind of importance which the emergency department has. Now let me come to my topic very briefly. These are the challenges which we are facing in the Indian healthcare industry. I think I will not go into the detail, I will skip that. And this, of course, is the NCD burden in India based on what we have in the Ministry of Health. This is the burden of harm as per the WHO, because we are going to, it is not showing there. ये उधर नहीं दिखा रहा, स्क्रीन पे वो ट्रांसफर नहीं हो रहा है ना. चेंज करें. Coming. Okay. Okay. Yeah. Okay. Yeah. यहाँ से भी कर सकते हैं. हाँ, यहाँ से भी कर सकते हैं. Oh, sorry. Actually, these were, the slides were not coming. So, because we are going to celebrate every 17th September, and at NABH also we have full-day conference in Delhi on the patient safety. And that will be doing. So this is, WHO has, prescribed, or rather this time mentioned, that these are the burden of the harm on which we will be discussing on 17th September all over the country. Now, this is the patient safety. Again, I will skip this definition. This is the quality in healthcare. I think we are all well aware about it. Advent of NABH in 2005 and 6 definitely has made a huge impact on healthcare quality in our country. I think today we have got more than 20,000 hospitals and nursing homes, either accredited or certified under the various categories. So we have definitely made a huge impact on the patient safety. But I would like to show you that whenever we talk of the quality, we must segregate the quality in two parts. One is the clinical quality, which doctors are aware, nurses are aware, which is within the boundary of the hospital. I have just put some of the points here, which are the components of the healthcare quality. Sorry, the clinical quality. Now, for example, the most important, I think everything is important here, but the clinical indicators which we measure and which we share with the NABH, we have now planned to do the benchmarking and bring out the index for each of the hospital, and which will be shared with that respective hospital, because that only will really make the impact that how individual hospital, individual doctors, their outcomes are being shared with each one of them. Similarly here, shared decision making, we are going to make a particular emphasis that in each in each specialty, how the clinicians sit together at least once in a week or once in 15 days, share their own procedures, whatever they have done, whatever the outcomes have come, whatever the problems. So this is what shared decision making we are going to work. Antibiotic stewardship is another area we are going to put a specific emphasis in time to come. So anyway, these are all the things, and last, of course, the special focus on critical care and emergency department. But what is the worry now? Worry now is that the hospital which have made huge advancement in clinical quality, surprisingly, I am telling you very openly, and this is the great concern, my personal concern, the service quality is coming down. Empathy factor is coming down. Communication is coming down. So I think we have to now make sure, I have given here some of the key factors which serves, because you must understand the patient, society, community, they will not know about your clinical quality. They have no understanding of what we are doing, but they will rate you on these very parameters. So I think somehow this is the area where the management of the hospitals, HODs, nursing directors, and most important is the people who are looking at the allied healthcare professional. So I think in the inaugural also somebody said about we definitely need to focus on them, because they only will decide whether your hospital is good or not good. So anyway, this is one I want to share you. This, of course, is the old diagram when we were making the accreditation. This again I am showing you because accreditation means patient safety, and patient safety is the sole responsibility of the physicians. I think initially a wrong impression went around that the accreditation is to be made, maintained, sustained by the administrators and those what we used to call as quality coordinators. No, sorry. Accreditation means patient safety is the fulcrum. And who are responsible for it? Surgeons and the physician. Then only we go to the nursing staff, paramedic staff, logistic, diagnostic. Management come all after that. And encompassing everybody is the accreditation. So once you say, I am accredited, that means you have gone to the accreditation right from physician, nursing, logistic, diagnostic, all administration, and then at the accreditation. So this is just to re-emphasize on you that accreditation is to be, ownership has to be taken only by the clinician, nobody else. Okay? And now, anyway, this I will skip for the time being. Now the question is that culture. You see, even today, whenever accreditation team is visiting you, NABH team is visiting you, 15 days before that, everyone in the hospital is told, prepare, the team is coming. Sometimes they even forget their own work. They are busy on creating the records, putting forward the SOPs, putting the other things in the biomedical equipment and everywhere. Question is, if it is a culture, you will not worry about it. Let NABH come any day, unannounced, let them come. You have a system, what I defined in the last line. If the hospital knows about it, everyone in the hospital knows what is to be done, by whom it is to be done, how it is to be done, and on what basis it is to be done, what we call SOPs or standard treatment guidelines. If these things are clear among each one of you, why should you worry about it? Let them come anytime. Because after all, what is NABH? Or what is accreditation? Accreditation is a framework for quality governance. So if you are being governed, or if you are governing yourself based on those few things, what is to be done, by whom it is to be done, how it is to be done, then why should you be worrying about it? So the issue here is that how do you establish the culture? I think somebody way back in United Kingdom, they had defined that this is the way a quality hospital should be working. And that is where I will not go into the definition, but the emphasis here is that it is a journey which is to be done by the empowered doctors, empowered nurses, empowered paramedical staff under the leadership. And so that means quality, you must understand, is to be led by the top management. The top management, if they tell you that, okay, we are supporting our quality team, that means you can think about that this hospital is not a quality hospital. Quality is to be led by the top management. So this is what actually they are working. And last two lines, which they are saying, that the staff working in the accredited hospital should be really enjoying the work. They must be adding value among themselves. It should not be seen as a burden, which many times I find people are complaining, what is this NABH, what is this documentation, unnecessarily a lot of workload has been thrust on them. That means you have done mistake in implementing the NABH. If you truly implement NABH, that means it is making your work easy. It is making you to commit minimum of the medical errors. And everybody then, there is no firefighting. So the NABH, if it is rightly implemented, everyone should be very happy because system is taking care of itself. You don't have to worry about it. You are part of this system and system is taking care of everything. So this is what is known as, now, as I said, that leadership has to take the whole thing. These are some of the important, definitions of leadership. And I think Dr. Satyajit Bose mentioned about one definition, which is from the bottom, number 2, the leader is the one who creates leaders. Good surgeon is the one who creates good surgeons. Good physician is the one who creates better physicians. And that is the second part of Dr. Abdul Kalam, where he said that good leader is the one whose trained leaders outshine him. So in fact, yesterday we were with Dr. Bose, and I was telling him that the physician or surgeon who are working with him, a time should come, it is already now I think time, that they should shine more than Satyajit Bose. Then we will say that Dr. Satyajit Bose is the good surgeon leader. Anyway, I think I'm sure it is happening. And so these are the various definitions. Now this is the culture part. Patient safety will come when the CEO or the chairman perceive himself or herself to be taking burden of the organization. That's why we show him in the bottom of the pyramid. We call it inverted pyramid. The good quality hospital is the one which works on the principles of inverted pyramid. Because in inverted pyramid, the top management is empowering HODs, consultants, they are in turn empowering the frontline staff, including the nursing staff, and the maximum empowerment. If you want to create best of the image of your hospital, please focus on the top line. If you are empowering, you understand, that means delegating with the adequate training. So, registration desk, day-to-day monitoring, OPD admission, OPD consultation, discharge certificate, fee collection. So, these are the areas, if you really empower and make sure, then your hospital, for example, discharge certificate, years have passed, we have not been able to solve this problem. But at least what you can do is, once the doctor declares patient, you are now discharged, it is over, you can go home, and he will say that at 10 o'clock during the first round. And after that, what happens? Nobody will visit the room, nurses will stop going to the room, paramedics will stop going to the room, and this patient is waiting in the room unattended for 6 hours. And that is the worst part which the patient feels about it. Now, how can you overcome? First, of course, there are a lot of things with the insurance. You can try to fasten, prepare the summary sheet before in the night itself. But at the end of it, please do not neglect him because your doctor has declared him discharged. Please keep on visiting, keep on asking tea, coffee, lunch, or whatever is there. He should not feel that now he is no more wanted in the hospital. Anyway, so these are some of the areas where you can improve upon. This is, a diagram which is I keep showing in the audience also, that how can you create the culture? You have to create the culture that each one of the people in the hospital, they should feel part of the team. Unfortunately, the way we play football in the hospital, we play the football in the hospital with the 4 teams. One team is of the consultant, one team is of the junior resident, one team is of the nursing staff, and one team is of the paramedical staff. There is nothing to connect all of them. At least 1 or 2 objectives should be there which bind them, that they feel we are part of the one team. And that is where the role of the top management is there, that certain objective they should define, review, and share with all 4 of them, all for the team. So that otherwise, I think you will be playing the game of football with the 4 teams, and that is not the way to establish the safety culture. And this is what I keep emphasizing. How can you bring the culture among the clinicians? I do not find at most of the places, I keep telling each HOD, each specialty HOD, at least hold meeting of all the doctors in your specialty at least once in 15 days. Review all the procedures which they have done in respectively. Which were the problem faced, which were the complication came, how did they solve, where were the problem from administration, where were the problem from nursing staff, where were the problem from diagnostic staff. Put them together in that meeting, and I tell you, within few months you will see the results. Establish the good teamwork. Junior consultant, junior doctors will be learning from experience sharing by the senior consultant. This is what I strongly advise if you want to establish the culture of safety. Bring this concept, operational meetings once in 15 days. And once in a month, all HOD should sit with the chairman and bring out the outcome of their meeting so that the chairman is also apprised of what is happening. So I think this is what actually the agenda of the meeting you can define, something like this. But this is what actually is the need of the hour. Otherwise, surgeons are so busy. Each of them will do 5 surgery, 6 surgery, 10 surgery in a day and go out. They will not share with any of their colleagues in the same department. So the responsibility now is of the HOD, and this is the simple way, because here you are bringing all the specialists in your own department, nursing staff, concerned nursing staff, concerned administration staff, concerned paramedics, their senior level, something like that, that can really establish the culture. So this is the takeaway from my simple talk, because I know we are running short of the time. The patient safety measures are to be led by the top management. There is nothing like quality coordinator. Please forget this word, that there is a quality coordinator in your hospital. He or she may be designated, he or she is facilitating others, but ownership is to be taken by each one of them, and this is the responsibility of the top management. Teamwork, as I mentioned to you, or rather empowerment is the mantra. Please focus on the empowerment and this other thing which I say, there is a ICN in the hospital. 400 bed, one ICN, 600 bed, one ICN. How can you manage infection control with one ICN? So the concept from Royal College of Nursing is each nursing station should have one link ICN. So please try to see that you have adequate number of nurses trained on infection control so that each nursing station has at least one link ICN present at all the time of regular review by the HODs. And of course, I think finally I will only say that leaders have to play the role of empowering their staff, taking reviews from time to time, communicating what you have achieved, what you have not achieved, so that they feel part of the whole team. Once you have that kind of team in your hospital, I can assure you that the CEO or chairman can take 10 days leave and hospitals will keep functioning the way it was functioning in your presence. So that is the crux, how you can create the culture of patient safety. All the best for this wonderful conference which you are doing. I am sorry I had to rush it because to save the time. Thank you very much.
Thank you so much, sir, for giving us an understanding of implementation and importance of safety culture in hospitals. May I now request Dr. Tirtha Mukherjee and the entire emergency team to please come up on stage and present a simulation on disaster preparedness and polytrauma.
ডক্টর গোয়েল বলে দিয়েছিলে না তুমি? না এটা না, ডক্টর গোয়েল টাকা।
ডক্টর গোয়েল হচ্ছে পরে, উনি হচ্ছেন এসএসকেএম থেকে এসেছেন।
আচ্ছা,
ওই সৌমিত্রর জাস্ট
হ্যালো,
সৌমিত্র গোয়েল একসঙ্গে।
ধর ভাই বাইরের দিকে আসুন, এখানে একটা ইয়ে হয়েছে।
হ্যালো,
ভিডিওটা কই? হ্যালো, কোথায় গেছে?
হ্যালো,
কোড ব্লু না, কি নামে ছিল বলো তো?
কোড গ্রে।
কোড গ্রে, এটা তো? এটা তো?
কতক্ষণ আছে এটা?
বেশিক্ষণ না,
বেশিক্ষণ থাকার কথা না।
গ্রে
2.59। হ্যাঁ,
এটাই তো? হ্যাঁ হ্যাঁ হ্যাঁ, দাঁড়ান এবার সাউন্ডটা দেখে নি। দাঁড়ান, এই সাউন্ড দেখো তো। এবার ভিডিওটা
এই
কি হচ্ছে? নামা, এটাকে নামা, দাঁড়া এক সেকেন্ড, এটাকে নামা, এটাকেও নামা। এবার ডুপ্লিকেট করেছি। সাইডে কি হবে লাগবে এদিকে গঞ্জ পেনড্রাইভগুলো কি ভাগ বলতে রেখে দেবো সরাবো না 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 কি বল
ইয়েতে কোনো জেনারেটর অপশন নেই
নেই
কথা বলে জেনারেটরের পাওয়ারটা
ও এখনো করা যাবে না সময় লাগবে তো করা যাবে
কথা বলে দেখুন না ওনার
আর লাগবে না তো দাঁড়াও ডক্টর তীর্থ ডক্টর তীর্থ হ্যাঁ এই তোমার লাগবে এটা টেস্ট করা আছে তো জেলি 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 হ্যাঁ জেলি হ্যাঁ জেলি আছে আচ্ছা 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 কোনটা ওই তো জেলি আছে এই ভিডিওটা ভিডিওটা এদিকে রাখতে ভিডিওটা
लॉग रोल कर ठीक है
एवरीवन रेडी তোমরা নিচে নাও
सुन
উজ্জ্বলকে শুইয়ে নাও पोजीशन में रहो so that I can identify everyone
पेशेंट अभी ला रहा है अभी रोकिएगा आपके बोलने के बाद तो लाएगा
हां अभी नहीं है
उधर हो जा
এটা খুলবো তো এটা খুলে রাখো এটা লাগবে না
उसमें तो
আচ্ছা আমি চালিয়ে দেবো আমি চালিয়ে দেবো আর চালিয়ে দেওয়ার পরে বন্ধ করবো বন্ধ করবো আপনাদের Good morning, everyone. Welcome to this August gathering in which we are talking about the most important part of our existence, our health. So, throughout the day-to-day lives that we are living, our emergency or our emergency care is like a lighthouse to which we gravitate to whenever we are having any sort of discomfort or problem. In the early days, it was like you had to wait for your child to come back, you had to wait for your family to be together before you could venture out, go to the nearest chamber to get the doctor, see you, and get your problems identified and solved. But we have moved away from that particular scenario around for the last 2 decades, and things have changed. We have moved towards the better healthcare by incorporating emergency care in our lives. So today we will be actually presenting a mock drill or a mock scenario where we will be showing when a mass casualty incident. Definition, mass casualty incidents, lots of people getting injured in the same accident or the same apocalypse. So that sort of a situation has happened, and then they have been brought to a particular hospital where they have a strict structure of the number of beds that they can accommodate at a moment of time.
But when these patients arrive, they are usually more than the number of beds which are available. So our resources gets overwhelmed. We actually put our hands up when we say that this is too much patients coming in at the same time from the same accident. So that is when we actually send out a message, a uniform message to the whole of the hospital. Like you have to come together and make a conjoint effort so that this disaster, this problem, it can be mitigated. So this is what is called code gray. There are other codes also. Code blue means when a patient has suddenly dropped, or patient or any other person who has become unconscious and dropped on the floor within the hospital premises. Code pink means a child has been abducted. Code white when a doctor or any hospital staff has been molested or injured or being victimized. So these are the codes. So these are announced and immediately people try to rush to the spot. Here code gray is usually announced in our emergency department and a similar scenario is being done. We have around 8 beds in our emergency department, and whenever more than 10 patients, 10 or more patients arrive to our emergency department from the same accident site, at that time we call it a code gray. Okay? So here's what we are doing. I am actually accompanied by my staff, Brother Jijo, who is the in charge of the emergency department, and he will be assisting us in identifying the problems and coordinating the efforts. Brother Pitush, he is going to look after the patient's vitals and put in the IV cannulas, and Sister Priyanka, she will also be helping Brother Pitush in putting in the IV cannulas and checking the vitals. Brother Alauddin, he will be helping in the procedures. Brother Chiranjit, he will be the airway manager. He will be helping the airway manager. And then we have our doctors, Dr. Rashid, who will be taking care of the airway. Airway means your mouth, your breathing, those things. When the patient is injured, the first thing, oxygen, water, light, that sort of a thing. So most important thing is the airway, so that we can take in the oxygen and we can thrive. So he will be the airway manager, and Dr. Shaumitro, he will be taking care of the other parts. Actually, in the trauma team, you have a trauma doctor also, and you have orthopedic surgeon also, or the orthopedic resident. So we are actually combining these two in Dr. Shaumitro, and he will be taking care of these issues. Okay. So we are having a code blue, so we have made a small video which we will start at the first, and then we will take the victim in. Lights.
না বিলকুল
আচ্ছা কোথায় হয়েছে? ও ঠিক আছে, কতজন পেশেন্ট? ওকে রাখুন, ওখানে থাকুন। কোড গ্রে। হ্যালো সিকিউরিটি অফিস 333 কোড গ্রে এমার্জেন্সি ডিপার্টমেন্ট। কোড গ্রে এমার্জেন্সি ডিপার্টমেন্ট। So we have already seen that one of the patients was gravely injured, and it was the patient was actually banded with a red trias tag. Red means that the patient is unable to walk, the patient is breathing more than 30 breaths per minute, the patient is unresponsive, not obeying commands properly, and the BP of the patient, blood pressure is low. So those sort of patients, they go directly to the emergency department. Rest of the patients are categorized into two parts. One is the placed the green tag, where the patient is walking wounded, while the other group is the yellow tag, who has all these things much better and can be taken care of within the next 30 to 40 minutes. So they are actually shifted to our critical care area. So we have bringing the patient in whose collar, cervical collar is already in place.
वन टू थ्री का ऊपर उठा चादर चादर था 1 2 3 vital slow, checking for the response. This is E2, V2 and M4.
Check vitals.
Torch. Pupils is equal 3 mm, reacting to light. BP bolo. उधर से
manually.
Pulse. Pulse.
Heart rate 140. SpO2 78 room air.
Heart rate 140. SpO2
78 room air.
78% on room air.
Respiration 42.
Respiration 42 per minute.
Okay.
BP 70 by 40.
BP 70 by 40.
Okay.
Please check the sugar.
Okay.
And checking for
Priyanka, Vitosh, put IV cannula 16 gauge in both hands and take blood samples for ABO and RH typing. Now also arrange blood for PRBC, FFP and platelets. Rush 1 liter pre-warm fluid and give 1 gram tranexamic acid IV bolus.
checking airway. Oral cavity is filled with secretion. Chiranjit, give me the suction. Clearing the secretions and give oxygen high flow mask.
So we are taking care of the airway and the breathing part, clearing the secretions
Airway.
and putting oxygen. At the same time, we are putting an IV cannula to start IV fluid. Because the blood pressure is low, the heart rate is very high, the respiratory rate is very high, and the saturation is low. So the patient is in a state of shock, hypovolemic shock, and there is severe hypoxia, that is decreased oxygen in the blood.
Trachea is shifted to the right side. There is subcutaneous emphysema on left side. Also there is decreased chest wall movement on left side. There is decreased air entry on left side. So there may be a tension pneumothorax. Priyanka, arrange for 28 French
Arrange
chest
for
tube.
intubation trolley.
So we are finding that the airway is compromised. At the same time, the blood pressure is low, which would entail putting a chest tube, which is a plastic tube which we put into the chest cavity to release the pressure which has been built out there due to collection of air or collection of blood resultant secondary to the accident, to the trauma, blunt trauma to the chest. At the same time, we are going to put in a plastic cannula within the mouth through and go into the through the voice box into the windpipe to secure the airway. So we are doing those two life-saving maneuvers.
Give me the laryngoscope. The 8 size tube with the stillate.
Fluids running, Priyanka? Fluids?
उसको fix करो.
Good, good. Okay.
Fix.
Blood bank के inform करो.
Check करो. Checking intubation with 5-point auscultation. Please, Dr. Soumitra, please.
Put a tube in position.
When the patient is in shock, there are multiple places from where the blood has been lost. It can be from a scalp injury, it can be from an injury at the back, it can be a blood loss or entry into the lungs, or it can be within the abdominal cavity, or it can be in the extremities and in the pelvis. So there are multiple areas where you can lose blood, and it is very much detrimental because your brain can thrive around 4 minutes without the lack of less substrates, that is our oxygen, nutrients and fluids. So beyond that, the brain starts having injury. So immediate treatment is the rule. The moment to identify, you act.
Intubation done with manual inline stabilization with the 8 size tube guided with stillate and checked with 5-point auscultation. Tube is in place.
Okay. 28 French chest tube is inserted, anterior to mid-axillary line in the 5th intercostal space. Air column is moving, and also there is air entry is improved from before on the left side.
Good.
Once again, reassess the patient.
Reassess,
vitals,
please.
Vitals, fresh set of vitals.
Please get X-ray, portable X-ray. Okay. We need to check the position of both the tubes.
Arrange the ultrasound machine for fast scan. Abdomen seems to be tense.
So we are checking with the help of an ultrasound probe whether there is free fluid within the abdominal cavity or in the lungs. So that actually helps us to clinch the diagnosis as soon as possible, which would actually push us into the zone where we are going to take the patient for the operation.
Sir, vital checking done?
Yes.
Check, show me the PRP.
Fast scan positive on hepatorenal pouch.
Okay. What is the blood pressure?
Sir, heart rate 120.
And also there is blood around the pelvis.
96 on ventilation.
Okay. So the heart rate has come down a bit from 140 to 120, and the BP has improved to 90/60. That means we are going in the right path. Resuscitation is progressing nicely. But there is free fluid inside the abdominal cavity, and it is considerable because it has been shown that it is between the liver and the kidneys, between the spleen and the kidneys, and also behind the bladder, urinary bladder, which actually tells us that there is lots of fluid within the abdominal cavity, probably blood, because that has caused the drop in blood pressure. So this patient is supposed to go to the operation theatre as soon as possible. Jijo,
going for log.
The OT. उनको बोलो stand by में रहने के लिए. I will inform the doctor. I will inform the surgeon.
So pelvis seems to be stable. Now checking for the extremities for any other injuries.
Check for other injuries. Start from the.
There is no deformity on the upper extremity.
Please expose the lower part.
There seems.
Okay. There is deformity on the right side of the thigh.
But
Put in a Thomas splint.
Okay, distal pulse present.
No external bleeding is present.
We have Dr. Rashid, please arrange for the Thomas splint.
Thomas splint, you have to इधर से तो log rod. उधर ऊपर एक दिखाना पड़ेगा ना. ठीक है, Thomas splint is in place.
Distal pulse.
Now again, we have got to log roll the patient. So the count of 3. Aladdin, please. One, Priyanka, you will see the tube that it should be in place while doing log roll. Hold the tube, chest tube, and you have to check with this. And counting 1, 2, 3, please log roll the patient.
Checking back of the head of the patient for any laceration or any fracture. Checking the back of the spine for any deformity. There is no deformity as such. Checking back of the extremities for any laceration or active bleeding. Back of the extremity seems to be okay.
Please
Now
put the patient
back.
3, 2, 1. Now again, check for vitals.
Ajay, cover the patient with a blanket.
With the blank.
Put in a Foley catheter. Priyanka, check the vitals.
Sir, vital checking done. Sir, BP 80/50.
Heart rate.
Heart rate 130.
Okay, so we have a problem here. The blood pressure is again going down and the heart rate is picking up, which means that the bleeding in the abdominal cavity is persisting and the patient will need immediate surgery. Okay, team, good resuscitation. Let's move the patient to the surgery. Jijo, inform the OT. Ask the security to keep the lift open. Okay, thank you. So that's how actually we do this sort of this is when we actually call in the medical superintendent, the medical director and the chief of operations to the emergency department and give them a briefing regarding the number of patients who had come, their addresses, their name, age, the demographics, and at the same time what sort of injuries they have, because often we find that we have a press waiting for our feedback or the patient relatives waiting for a feedback. So for that joint decision making and joint consensus is necessary to express or relieve the patient relatives from their mental agony. So that is done. Thank you. Thank you all for your patient seeing, observing this. Yes, sir. Please.
One question for you. Yeah, tell me.
Actually, it's a nice presentation. But one question is that you have told it's code gray, but according to the NABH, it will be code yellow.
No,
And
in our mission hospital, we actually made it code gray here.
So can it be based on the institutions? One can
Yeah,
decide?
institutions can change. Institutions can change.
And as per the definition, it should be the total number of beds, 3% when the patients will come at a go, then it will be, the code will be
No,
announced.
that again is our own preference. Ajay, 1 second.
So this is, I will, this code gray for the mission hospital, we have our standard. More than 10 patients at the same incident occurring at the same time, we declare code gray in the institution. This is the protocol of our institution.
Beyond that, if something happens and we cannot tackle the rush, then we actually move the patient to other hospitals too. But in the USA, I know that in the different districts, they have their own codes. Some of these are very much clear, like blue is blue almost everywhere, pink is pink, but this gray sometimes becomes orange and sometimes becomes yellow. So that actually changes, keeps on changing. Okay.
Hello,
Thank you.
sir.
Yes.
One more question, sir.
Yes, ma'am.
Acha,
Please.
what about the stitching of external cut injuries?
Ma'am, currently we had not found any external injuries, but that is also done at the same time. It is more proper if you have a stapler at hand, because that actually saves time, because it will cause a sort of a tamponade effect once you have covered the gash which has formed. If you cover it up, then the blood keeps building up there, and you put a tight pressure bandage, especially in the scalp. In the other areas, if you have too many people around and you can make it, the resuscitation is going nicely, the vitals are holding steady, and the patient looks stable enough. So in that case, you can go for a detailed suturing to stop the bleeding and all that. Otherwise, you can also use tourniquet. In the limbs, you can have tourniquet. We have medical grade tourniquet. We have a tourniquet. This is a medical grade tourniquet. Or you can also use tourniquets which we use to draw the blood. Okay, so that can also be.
Okay, thank you.
Check.
Sir, if the blood pressure is, if the patient remains unstable and you have a source which shows that there is bleeding in a unobtrusive way, means an obscure bleed somewhere, so that needs to be staunched. If it is on the external surface of the body, you can definitely do something about that. But if it is in an unreachable part, then that needs to be approached or reached as soon as possible. It is the safest way to do. So in that case, we actually inform the surgeon who is on call, and they take the patient up. If they find something untoward which needs some more consultations, say you have a pelvis injury, it's bleeding inside, though we can call in the urologist. We can even transfer the patient from the 3rd floor where our OT is to the 2nd floor in the cath lab, where we have done this thing, embolization, to stop the bleeding in the internal iliac and those arteries. So that can also be done.
Yeah, that is what I
so
think.
that
Defense officer will assess,
Yes,
and
sir.
then to take the next decision,
Yes,
the
sir.
other
Yeah,
sometimes
sometimes imaging are also very much necessary. Here we had showed that the patient is in altered mental status because of low BP and all that. The CT brain was not advised, because then the patient, unstable patient, had to be taken to the gurney, where the patient could have deteriorated and went into arrest. So to avoid that. Yes, sir.
I think there's a point which is very relevant that he is raising, and that's a concept which is called as a polytrauma patient. Now, this is a patient who's got polytrauma. The reason for that is he's got a GCS which is low, he's got significant abdominal injury which is causing hypotension, there is blood in the abdomen, there is injury of the chest. So when more than 2 systems are involved, when there is hypotension, it is better to organize something called as a polytrauma team. So this is for you, Dr. Partho, that I had to mention, that one of the things that you can look forward to developing in your institution, which is so proactive, is to form what's called as a polytrauma trauma team. So whenever there is a polytrauma who comes in, the trauma team needs to be activated. They need to come in, and together, synchronously, they will assess this polytrauma patient and plan a strategy by which, if necessary, 2 or 3 teams can together operate in the operating room. So that's something
Yes,
that I would like
That's
to
the
add
standard
on to you.
protocol, sir.
Yes.
Thank you,
So
sir.
that's what needed to be clarified, and your point is very well taken, and thank you for bringing that up.
Yes, actually I mentioned that a general surgeon and an orthopedic resident, they should be present in the team, along with an anesthesiologist or a EP emergency physician taking care of the airway. So that is the usual norm. Thank you, sir. Thanks a lot.
Thank you so much, Dr. Tirtha Mukherjee and the entire emergency team. May I please request Dr. Giridhar Gyani, sir, to please come on stage and felicitate our emergency team led by Dr. Tirtha Mukherjee. Individual mementos are in the department team. So this is I would like to call upon stage Professor Dr. Suresh David, Medical Director, Pushpagiri Medical College, Tamil Nadu, to please deliver keynote on disaster preparedness in hospitals. So.
And the presenter, please.
Presenter? No. That is presenter. Oh, yeah.
Yes. This is the Yes, sure. Please go ahead.
There is a workshop going on the 4th floor, requesting the nursing team who are going to attend the workshop to please move forward to the 4th floor. The workshop is in the 4th floor. Nursing team, if you want to participate, please move to the 4th floor.
Check. Turn it on. No, it's not working. Not working. Not working. Yeah. Good morning. I think that was a very good opening that we had, a little bit of action on stage, and I think I will continue by walking about a little bit, because being an emergency physician, I'm not used to sitting down for too long. Before we proceed any further, I just wanted to ask you, how many of you are aware of the theme of this meeting? Can I have a show of hands? How many of you know the theme? Yes, just about 4 of you. And the rest of you are unaware of it. The theme of this particular meeting is re-engineering of emergency care. Now comes the next question. How many of you are aware of the meaning of the word re-engineering? Can I have a show of hands? Hardly anybody. Just a couple. Well, I think it's important for us to understand what that is. Re-engineering actually is a management term. And re-engineering, the full form is actually business process re-engineering. And what re-engineering means is when there is a process in an organization, and if you want to see an improvement in the quality of delivery and the outcome, you need to look and analyze what exactly is the input, what is the processing, so that you can have the effective output. So you need to analyze, if necessary, redesign, and then expect the outcome. And I was quite surprised when I saw this term being used, because I've not seen this for a very, very long time, because I used to talk about this when I used to talk about management. Because apart from being an emergency physician, I'm also a management scholar. And I've taught management, and it was no surprise when there was one person who spoke to me and invited me for this conference. He is one of the unsung heroes of this meeting, because I have not heard much of the mention of his name. And he apparently was a student of mine, and he learnt this from a lecture of mine where I was talking about re-engineering of the emergency department. Ladies and gentlemen, I want to present to you the medical director of this hospital, Dr. Partho Pal. Partho, can you please stand up? He is the one who named this conference as Re-Engineering, thank you, please. Re-Engineering of Emergency Care. So, among many other things that we do, one of the important things that we need to do is to analyze and see how well are we prepared as an institution to handle when there are disasters. So I'm going to take you through some of the slides that I have here put together, and this actually comes from an acronym called HOPE, Hospital Preparedness for Emergencies. It was about nearly 12, 13 years ago when the United States Agency for International Development put 5 of us together. I was from India, we had 2 people from Indonesia, we had 1 from Bhutan, and 1 was from Nepal, and we came together to draft a training program which we called as HOPE, or Hospital Preparedness for Emergencies. And we ran this program, conducted this program, and we, after developing it over 5 meetings that we had in Nepal, and we ran it across all the countries from Pakistan all the way up to Philippines. So some of these things that I'm going to talk about are basically the tip of the iceberg from the course of Hospital Preparedness for Emergencies. Disaster medicine is one of the subspecialties of the broad specialty of emergency medicine. And in that comes hospital preparedness, which is just but a tiny portion of the whole thing, and of which I'm supposed to talk to you over the next 1 hour. Normally this will be 5 or 6 lectures, but I'm going to condense everything together and give it to you in a nutshell as to what exactly does it mean. So before I proceed, I want to know how many of you are from hospitals outside the mission hospital. Can I have a show of hands? Oh, excellent. I'm very happy to know that. Because what you see here, I'm hoping you'll be a messenger and you'll take it back to your respective institutions and see how you can empower your hospitals to be prepared for emergencies. So the origin of the word disaster comes from Latin. It comes from 2 words. One is aster. Aster means the star. That's why astronomy, astrology. Latin is actually the mother of English. Many words from Latin are the ones which have come in, have been incorporated into English. So aster means a star, and dis, as you know, is dysphoria, dysphonia, dysphagia, dysarthria. Everything means disordered, basically. It's not something which is good. The people of ancient Greece and those areas believed that there was a malalignment of stars which resulted in a major catastrophe which affected people. And they called that as a disaster. Okay. So what exactly is the definition of disaster? It was just about 10 days ago when my wife told me, you know, I was baking a cake, something new that I was trying out, and it was a disaster. Now, is that truly a disaster? It's a disaster for her because, you know, she thought it'll turn out better. But what exactly is the definition for disaster? And the definition is a disruption which is causing widespread human, material, economic, or environmental losses which exceed the ability of the affected community or society to cope using its own resources. So you see the most important word in this, the anchor word is exceed, beyond. We just saw a moulage which was done on mass casualty management. The department managed it very well. They wanted help, the organization comes together to help. But it did not exceed the resources of the institution. So it's not a disaster. A disaster requires to be overwhelming the institution, necessitating assistance from elsewhere. So the tendency of disasters basically is three things. One, it interrupts whatever is going on. The normal functioning of a community, of a country is interrupted. It exceeds the coping mechanism of the community and it requires external assistance. So these are the three main conditions which have to be there in order to define something as a disaster. Now when we look at the epidemiology, what exactly happens? Unfortunately, most of the world's worst disasters occur in the poorest nations of the world. In other places where it happens, it is managed by the respective countries. And it is also seen that 90% of all the deaths from disasters occur in low-income countries, which is very unfortunate. So there are a few terms which I want to introduce to you. Whenever we are looking at disaster, there are a few terms which we need to be familiar with, because if we do not use it correctly, they tend to get interchangeable and the meaning is lost. Hazard, vulnerability, risk, fourth is mitigation. So these are four words which I want to talk about. So the first word, I want to show it as an image. So when you look at this picture, what is coming into your mind? I want to know. I have been a teacher for more than 35 years, so I'd like to make sure that whom I am talking to are walking along with me. So therefore, in your opinion, when you see this picture, what comes to your mind? Would anybody like to? Yes, please. Exactly. So there is a blind spot further down, but what's there in the foreground? Yes. I like the way he put it. He says it's an invitation for a disaster to happen. Would you like to elaborate on that so that the others are also with you? Exactly. Exactly. Thank you. Thank you very much. So basically, as he beautifully put it, we are inviting a disaster to happen because it's an unmanned level crossing. An unmanned level crossing is what we refer to as a hazard. This is a hazard, which means it is a process, a phenomenon, or a human activity that may cause a loss of life, injury, or property damage. So that is a hazard. Okay. The second is this particular picture. This is from your neighboring state, occurring right now as we speak. It's the uprise of the Brahmaputra, and this is something which occurs every year, practically every year. People are aware of this, the state is aware of this, and this is something which happens. And this happens because these people, the poorest of the poor, are vulnerable. Okay, they are vulnerable. So therefore, these are conditions which are determined by physical, social, economic, and environmental factors. In this case, it's the socio-economic factor, which increase the susceptibility of a community to the impact of hazards. So you see how a hazard and vulnerability are related when the population is susceptible or vulnerable to a hazard to occur in their premises and in their midst. The third one is called risk. You look at this image. This is in Indonesia. This particular mountain, which is known to be a volcano, had been dormant for 400 years. Then it erupted. And it erupted and caused a lot of damage. But for 400 years, it remained dormant. Does that mean it's going to remain dormant forever? Not really. 400 years later, it happened. So therefore, risk is where there is a probability that the consequences, because of its presence in their midst, can cause an interaction between the hazard and the vulnerable conditions. So therefore, what you understand by these terms so far is that sometimes disasters are not preventable. Landslides are preventable. Many of these things, like the water surge which happened in Chennai in 2015, was preventable because those are man-made conditions which made that situation vulnerable for a disaster. However, many other natural disasters, no. You cannot prevent what nature has decided to do. But what is it that we can do? What we can do is mitigation. Mitigation is a word which we use specifically in disaster management, and mitigate means to lessen the consequence or to reduce what exactly happens to the population at risk in the event of the disaster occurring. And there are levels of disaster. First is where the management system is adequate. Okay, the local disaster response management is able to manage it. The second one, where it requires the whole town or the district or the state sometimes to come together. This is a level 2 disaster. And a level 3 is where the entire country, this is where the National Institute of Disaster Management and the NDMA, for example, most importantly, National Disaster Management Authority, steps into the picture because this is a level 3 disaster. And level 4, of course, is international help is required. So these are the levels of disasters based on the resources, but as you see, primarily it exceeds the capability of the institution to manage the situation. Now, one of the first experiences that I had when I returned back from Australia after my training in emergency medicine, before that I was one of those mundane upper GI surgeons. The only thing that I was doing was esophageal surgery. The only patients I saw in the OPD was those with esophageal problems. All the patients in my unit were all esophageal problems. From that I moved into emergency medicine. I trained and I came as part of my registrarship, as part of my training, I had learnt about disaster management. But still, studying is something, putting it into practice is totally different. So this was in 1995, when Vellore has one of the 4 TELs, Tamil Nadu Explosives Limited, TEL, they have, where they manufacture dynamite, industrial level dynamite. Those buildings are really beautifully built because they always have the vulnerability for an explosion. Sure enough, there was an explosion which occurred, and when an explosion occurs, it does not explode. The building implodes, which means it falls within. And that's what happened. And all the people who were inside were trapped inside. Of course, of the 29 people, 27 died. And I, in my early stages, was so enthusiastic that I went there not realizing that I became vulnerable because there was a hazard. And I was right there trying to see what I can do. And that's one of the mistakes we must not do. Today we know that we have a place to be. We have a role to play. We cannot jump in there and go like the heroes and try and save people because there's a risk that we can be injured in. So similarly, the Indian Ocean tsunami. This is something which I had the privilege to be there for providing emergency medical response. Because, as you know, it started in Aceh, in Indonesia, and it moved up into from the Indian Ocean into the Bay of Bengal and affected the coastal areas of Tamil Nadu, Andhra Pradesh, and all the way up into Orissa and a little bit of West Bengal also. So now, on December 7th, 2004, because tsunami occurred on December 26th at 9 o'clock in the morning. And I was away at home, far away from Vellore for my Christmas vacation. When I came to know of this, I left immediately. It takes me 10 hours to get from my hometown. I come from a very small town in Tamil Nadu, so I had to travel all the way to Vellore. And while I was on the train, there was not much of mobile phones and all that those days, so therefore there was not much I could do. Only after getting to Vellore, we organized ourselves and moved together as a team to work in this area. And we were working in this particular area called Tarangambadi. And Tarangambadi was one of the worst hit places, and that particular district was the one which required maximum help. So we were there, we traveled and we went there, and to me, it was the first time that I was providing this emergency medical response for a tsunami. People did not even know the spelling of tsunami, because it's not something which happened here. It's a Japanese word. But we learnt it in disaster medicine, so therefore I was able to help and guide the district authorities also. The collector and I, we were working together very, very well, and the whole team, we worked together so well. This actually was a place, a town called Pumpuhar. It's a very old town where the government of Tamil Nadu had built up beautiful granite buildings, huge big buildings made out of granite and sculpture, and all that remained were those two little carvings which stood there. The rest, everything was destroyed. So the waves were so big that they took away everything. And it is surprising that although the foliage and the vegetation of the ground was completely stripped, the coconut trees still stood tall. It was unbelievable, because we really don't know what nature has, but the coconut trees stood unfazed, whereas everything man-made, everything on the ground, all that was completely washed away and taken back into the sea. Tsunami caused maximum mortality with very minimal morbidity. Hardly anybody was unsick. I mean, there were lots of patients that we saw, but the number of people who died, bodies strewn everywhere. One of the things we had to do was basically make sure that we get all the bodies and put them together so that some identification can happen, because people were scattered all over that area and they died, and they were either taken back into the sea or they were left there. So we had to collect all the bodies. And that's one of the effects which it had on me also. So I will talk about it later when I get there. So the bodies were strewn everywhere, and we were helping the fire service, and the local people were so supportive. That's one thing that I noticed in India. We are very proud of the fact that when there is a major issue, the local communities come forward to help. Exactly opposite to what happens in the United States. When there is a problem, first thing they do is leave. Second thing they do is come back and loot everything that is left behind. Because we saw this in Katrina. So when Katrina was hitting the district's New Orleans area, the first thing that everybody did was all of them vacated the houses. The next thing was a wave of people, of miscreants who came and looted all the shops, looted all the homes, everything they took. This is something we do not see in our country. The people were so helpful, and we came across and we saw these 4 brothers, and we asked them, "What are you doing on top of the building?" And they said, "We are searching for our mother. She should be inside." Obviously, she was not alive, but she was inside. So we split ourselves into 2 groups, and we saw the teamwork that was being done, so beautifully demonstrated. Teamwork is the key when it comes to disaster management. And this particular team of mine, 2 teams, we had 2 vehicles, and in each team, there was a doctor, a nurse, a pharmacist, and a driver. And the driver was not just a driver, he also was responsible for food distribution. Each one had designated responsibilities, each one did their job beautifully. And we worked from 5 o'clock in the morning till 6 o'clock in the evening, every day. That was our work, and we worked continuously. And there were many things we had to do. One of the most important things was pediatric screening, because children were affected by 2 kinds of problems. One, injury, which they suffered from, and the second was submersion injuries, because the water came and went over their faces, and there was submersion injury. They had many of them had pneumonias of varying degrees. So these children required a lot of screening, and pediatric trauma was also something which we had to look into, and we worked for about 7 days over there. We had to leave prematurely because there was the fear of the second wave of tsunami coming in. So we got an alert from the Meteorological Society and said there was a high risk, so all rescue teams had to move away from there. So we could not continue for beyond 7 days, but I think we did a good job. We conducted 38 camps in different places. I used to be in one of the vehicles and travel between my two teams. So two teams used to work, and I used to go back and forth, especially when they had patients which required a little bit more of expert help in assessment. So that's how we looked and worked. This is yet another situation which happened in 2007. This is where there was a train accident very close to Vellore. About 30 kilometers away, there was a train accident, and we were called by the district collector to come forward and help, because we were a major hospital at that time and there were no other medical colleges in Vellore at that stage. So we worked very closely with the government, and the government had invited us. 2 of the bogies had derailed, and there were 150 patients who were involved in that, and we were involved in the management of this. That's my team over there. And what we did was basically look at on-site disaster management. And on-site disaster management consists first of on-site triage. We heard about triage. Basically, you are choosing which are the patients who need to receive the right treatment at the right time. That's what it is. So there is a system of triage, there's a method of triaging. I don't want to go into those details, but this is one of the responsibilities which I am letting all of you know, because there can be a time when your hospital may be invited to be participating in an on-site management of a disaster. So when that happens, your hospital needs to move and come forward. You cannot be putting together an action plan at that time. So the second thing you will need to do is to establish a field first aid station. So these are the 2 very important things which we need to do as emergency physicians. How many of you in this, you may be a nurse, you may be a paramedic, doctor, how many of you are involved in emergency medicine? Can I have a show of hands? Okay, very few of you. How many of you are in management? Can I have a show of hands? Okay, more number of people. See, you may be an emergency physician or an emergency care provider, you may be a manager, but both of you have equal responsibilities as far as your institutions are concerned. You're very well aware of this. This is the Jagannath temple, which is in Puri, which happened very recently also. I want to now just touch upon mass gathering medical care. This is one of the responsibilities of emergency departments, and this is how hospitals get prepared. So what exactly is mass gathering medical care? It is the organization and provision of emergency medical care. And this emergency medical care, you also are doing it for planned events. See, until now, you are managing an unforeseen or an unforetold emergency. This is a planned event. So therefore, you will be called upon as a major institution or as a medical institution in your area to provide emergency care for patients or for people who are gathering together for a planned event. And the difference is that these are not patients. They are basically healthy individuals, apparently healthy individuals. So they are coming together for a common purpose. They are not coming for medical help. They have come together for a common purpose, and they require emergency care. So the potentials are 3. I call them the 3 I's. First is illness, second is injury, and the third is infectious disease outbreaks. All these 3 things can happen whenever there is a mass gathering of any kind. What is the philosophy of mass gathering medical care? It is basically to provide a safety net. These are actually Chinese safety nets which are there. Some of you who might have visited Cochin, you will see that this is there. These are put under the water level, and they are left overnight. Nobody touches it. The fish get used to it. The fish are all above that. But there is a net underneath. So what we are doing in mass gathering medical care is providing that fish net so that these people know that there is a fish net or there is medical emergency available, and you have to act as and when there is a need. I just want to go back to President Kalam's visit to Vellore. So he came and he wanted to meet only children. I mean, those of you who know about President Kalam, you know that he's very passionate about children. So he wanted to have a gathering of children whom he would address. Now, which school to choose and which not to school becomes a problem, and ultimately we had 60,000 children who were meeting inside a fort. Vellore has a fort. And inside the fort, we had 60,000 children. Now, there are certain problems when we do this, because there are certain critical issues which we need to look into whenever you're planning for mass gathering medical care. First and foremost, you should have an idea about the crowd size, because when you know the crowd size, then you know the number of people who are required to be there. Second is the weather conditions. Unfortunately, this was during the summertime, just before the schools would go on vacation. So to the height of summer. So therefore, there are certain problems associated with high temperature, as you're all aware of. Third is duration of the event. Now, before the president comes 3-4 hours earlier, everybody needs to come and be seated. So the president would speak for half an hour, 45 minutes, but the people have gathered and they are there for about 4 to 5 hours. Layout of the venue is very, very important. My major concern, which I was sharing with the collector, is that I am very, very worried about this particular venue that you have chosen, because there is only one entrance exit to the fort. Like all forts, there's only one outlet, inlet together. So in the event of a problem inside, let us say there's a miscreant who decides to blast a bomb, or there is some mass stampede, I mean, everybody needs to come out, we're going to have a major problem. So this is something that you will need to do, and you need to discuss with your mentors and those who are your counterparts and your administrative teams which are organizing this. Of course, it requires three things. It requires triage, medical care, and transport. These are the three requirements which we need to provide whenever we are doing this. And waterborne diseases is a major problem. And waterborne diseases, for example, there was a state conference of the political party in 2014 in Madurai. And where they were meeting, there was actually the main sewage which was going through. So people were crossing, and this is actually sewage water, and people are crossing through that. So you can imagine the disease outbreaks which can happen because of this. But sometimes people are not aware of this. We as medical people need to be aware of this. We also need to have a rough idea as to how many people are required in terms of staffing. And it is said that for every 10,000 people, 2 paramedics are required, and for every 50,000 people, 1 or 2 physicians are required. So that's the ratio which we as organizations need to provide. And for on-site personnel, if we train our emergency department nurses and paramedics, we should be able to handle the situation there very, very well. And the medical personnel, it's better to take physicians who have a significant EMS experience and emergency room management, and because by having them, you have an advantage. Emergency physicians will make sure that they do the triaging properly and transport only those who are required. And many studies have shown in mass gathering, if you involve emergency physicians, the number of transports to the hospital is significantly reduced. So now we move on to another thing which I called as an incident. An incident is basically what you would call as an accident, but nothing is an accident. Everything is an incident. Most things are not accidents. They can be prevented. They are incidents. And incidents are of 2 kinds, which happens to a medical organization. One is inside the hospital you can have a problem. Second, a problem can occur outside the hospital and patients can be brought in. You all know very well what happened in Jabalpur very recently. There was this massive fire which occurred in a hospital and 8 people died. And I know exactly what happened in my own hospital in CMC not now, a few years ago, where there was a fire, electrical fire, which occurred inside the OT complex. We had a total of 18 theaters, and this is at 3 o'clock in the morning, afternoon. So you can imagine all theaters are functional. There are patients in the waiting. Patients are on the table, many of them are actually paralyzed, they are intubated, surgery, abdomens are open, skulls are open, chest is open, and suddenly there is a fire. So an incident can happen within the institution. How prepared are you? How do you prepare? So that's what I'm going to talk about. How do we prepare for this? And there was a moulage which they put up about mass casualty management. And are you prepared you were prepared for 10 patients, 12 patients. Let us suppose 2 buses collide. It happened in Vellore. I had 44 patients who were brought to my department because 2 buses collided. Are you prepared for it? How exactly will you mobilize and activate your systems in order to do that? So the question at the end of all this that you have been listening to is, how do I, as an emergency physician or as a manager, how do I prepare my institution? How do I plan for a disaster management? I want to introduce one more term which the United Nations Office of Disaster Risk Reduction is called UNDRR. They have defined, and this has actually become the buzzword now in all disaster management. It's the application of policies and strategies to prevent new disaster risk, reduce existing disaster risk, and manage the occurred risk. So 3 things: prevention in future, if possible, or mitigation. How exactly do I manage the existing disaster risk? Many of us are there. There is a hospital in Kerala called Lake Shore Hospital. So you can imagine what can happen to it. There can always be a water surge. So are you prepared? That's the question. Similarly, if there is a risk which has broken and there is a disaster, how exactly do you manage this? So management of all these 3 things, and application and devising a policy to suit your hospital. There was a very good question that you asked where you said, how is it that you decided 10 patients? Every institution should decide based on your resources what exactly you need to do. I was a principal assessor of the NABH once upon a time. I could not continue because I became the medical director of a medical college hospital, and therefore I did not have the time to go for assessment. But I know very well that the NABH does not tell you, do this. NABH provides you guidelines so that you can devise your own guidelines. So therefore, every institution has to customize based on the guidelines that are provided to you. So what are the elements of disaster risk management? Basically, first and foremost, as I said, excuse me, prevention and mitigation. Some disasters we can prevent, many others we can't prevent because we are at the risk of developing it, or we are vulnerable because we are in a situation, and all we can do is to mitigate. Take for example Japan. Japan is in the earthquake belt. They can't prevent an earthquake, but they've got fantastic systems in place to mitigate. When there is the possibility, when there's a probability of an earthquake, their mitigatory measures are fantastic. Early warning systems, evacuation, etc., etc. It's beautifully designed, very well done. Second is preparedness. Once you know what you need to do, next thing is to do what you need to do. So first is to know what you need to do. And second is to do what you need to do. And the third is to do what you need to do. And that's when you swing into action when there is a problem. But after the action is over, recovery is very, very important. And I will tell you about this as to why it is appearing so important, because quite often we forget about recovery. When you see many of the world literature, they will talk about incident commander, command system. It's all based on the military. Okay. Because disaster management was derived, many of the rudiments were derived from the military, and many of the terms we talked about command and everything else. The problem is in hospitals, we as doctors generally don't like to be commanded because our egos are bigger than ourselves. And we think we are God's gift to mankind. So therefore, we don't like to be led. But we don't mind being coordinated. So I don't like to use the term commander. I like to use the word coordinator. So I'm not a commander, but I'm a coordinator. So my job is to make sure that I get things sorted out. I'm not going to give orders to you. So these things are what I call is indigenization. Whenever we see protocols, whenever we see any strategies and guidelines, we need to make sure that it is applicable to us, to our needs and our resources. Quite often that doesn't happen. So have a disaster management coordinator, and the action plan for you is first to form the team. Form a disaster management team. Pick people from different areas, put them together, analyze the risks. That's very important. What are the risks that your respective institution can be susceptible to? Analyze that, and then you prepare. And you prepare a comprehensive action plan. It is important that your action plan is comprehensive. It needs to address all the risks that your institution can be prone for, and you must put it to test. Don't wait for the disaster to happen. Make sure that you run your mock drills, analyze what exactly has happened, make the corrections that are necessary, because we are prone to make mistakes. We don't want to learn after the disaster has occurred. It's better for us to fine-tune and tweak our processes and our protocols in such a manner that we will deliver a flawless action plan when it is required. So the roadmap, as I call it, for an effective disaster risk management is to do what's called as a risk analysis. All these are disaster management terms, okay? How does the team, okay, we have formed a team. The team is sitting together. You need to do brainstorming. And that brainstorming is called as what-if analysis. What if basically is throwing ideas in the air. What if I have two buses colliding just outside my hospital? What happens if there's a big flood or rains and there is water surge into my department? What happens if there's a landslide outside and none of my staff are able to come in? See, that's also a disaster, okay? Something happens outside the hospital which prevents either personnel or your supplies to come into the hospital. That will incapacitate your institution. So, what if analysis basically helps you to analyze and enumerate all the problems that you have, and that helps you to prevent this single all hazards plan. That single all hazards plan should be practiced again and again, and that helps you to make sure that you're prepared. And when that happens, you have, everybody is fond of this term, Incident Command Center, which basically comes from the US Army. It's not that I have anything against it, because everybody uses it, and you go for any of these disaster preparedness programs, you learn about it. Very difficult to get out of it. But call it what you want, but that's basically the nerve center where all the planning, the strategizing, everything happens. And you run your mock drills and make sure that you integrate. This is very, very important. And I heard that emergency physician say, when he is unable to manage, he calls for help from other organizations. Networking is very, very important, because there is a possibility that you may find that the requirement exceeds that of your institution, in which case you will require the help of others, of other similar medical institutions. And you may together have to go to address a level 3 problem which is occurring somewhere else. So therefore, networking among emergency departments is very, very important. And the management also needs to see eye to eye with other institutions, and you have a program. When there is a problem, you have to have a responding system. And we saw that the doctor was showing in code gray that he rings up, speaks 3 times, and the telephone operator does the rest. They ring up the respective areas, and then they carry out the activity that is necessary. The next step, which is also very important as part of the response, is to make sure that you're supporting the mechanisms. The support mechanisms for the staff. Don't let them be there forever and ever. We learned this lesson with COVID. Our doctors, our junior doctors, our nurses were burnt out because we could not provide the number of replacements, substitution, rest and respite for them. So it is very important that we make sure that we have a support system also which begins to play, which begins to get activated while the main team is playing. You need to make sure that you give the replacement so that they will have the necessary rest that they require. Recovery is very, very important. And this is where debriefing is something which is of utmost importance. Whenever there is a major disaster in an institution, we function beautifully, and after that we shake hands with each other, pat each other on the backs, and we go home. No. Many of these disasters, many of these major incident processes have a lasting psychological impact on the healthcare giver. And I was telling you that when I was working for 1 week, helping them to remove bodies, helping them to put them, what we were doing is the JCBs were working huge big graves, and we were dumping people inside because we couldn't keep them for more than a particular period of time because decomposition happens. We can't keep them outside. There are no mortuaries. We're talking about villages. So after some time, the bodies were disfigured, that nobody could identify them. So from one side onwards, mass burials were going on, and we were helping them to put the bodies into those graves. Nobody knows about this. We know, we have experienced. And believe me, for nearly 6 months, I used to wake up in the night in a cold sweat, and I could smell the bodies, and I knew that I was helping them to transfer that, and my adrenaline was running. Why did this happen to me? It is because there was nobody to debrief me. I debriefed people, but nobody debriefed me. So what I learned was the importance of debriefing through a personal experience. So debriefing, for those of you who are in management, those of you who are in administration, those of you who are going to be tomorrow's administrators, make sure that the recovery phase is addressed properly. And then amendment, revision. We are constantly learning. Whenever we go through either a major incident or a disaster, there are lessons to be learned. There's nobody who's an expert. There's nobody who has seen it all. Unless you've been in emergency medicine like me for the last nearly 3.5 decades, where I've had the opportunity to see many things, including as late as 2015, when I had to take 2 teams once again and work among the water surge areas which had occurred in Chennai, near Chennai, in Pondicherry actually. So, therefore, the key questions for managers that you need to remember is, what hazards exist in my area? What are the potential health consequences from disasters? What role does my hospital play in the disaster response of my community? Lastly, does my hospital have a plan to manage and coordinate disasters? So these are the key questions which need to be remembered and answered by managers and those of you who are helping the management with disasters. And over the last 35 years, what I have learnt is that it is not technology. And I'm very happy in a place where I'm looking at affordable care. Because the world is moving towards becoming more and more technology dependent. But as far as disaster management is concerned, technology does play a role, especially with prevention, mitigation, and all those areas. Technology has got a significant role. Early warning systems, etc., no doubt. The world is changing a lot. But when it comes to actual care on the floor, at the site, three things are important: knowledge, confidence, and compassion. Usually it's compassion which drives us to go and help. Knowledge and confidence is also very, very important. Because, ladies and gentlemen, all said and done, one of the things that we tend to do is when we look at a system in the US, we think we can do the same. What we do is we take from the book and try to transplant it into India. No, it doesn't happen. Many of our resources are very different. We cannot expect our country to do the same thing which is being done in the US or in England or some other place. Because we are different, we do things differently. We do not read a raft. Look at this mother, how well she is taking care of her child with one of the vessels from her own kitchen. So it is important for us not try and transplant a system from overseas. Indigenize, improvise. Those are the two mantras which I would say. Read about it, but you devise it based on your needs and your requirements. Because all said and done, remember one thing: technology can improve. There is no end to the development of technology. But never forget that the principles of disaster management remain the same. Thank you. Thank you.
Yes, sir.
With permission from the anchor, I cannot check my temptation to share my views. Our speaker just now addressed us on management, disaster management, digressing from the medical science and talking about the situation that we face, and most cases unforeseen situation. But sir, I just tell you, I share one of the incident that we faced during COVID. There are situations which you cannot anticipate. And there are situations when it comes, you cannot decide what to do because you are not experienced with that situation. What happened during COVID, may I share? A particular hospital I am not naming, every hospital in the country faced a tremendous difficulty during second wave. And sir, successfully, we are proud in Bengal, our patients did not die on the road. It was only possible because of the untiring effort given by the private and public health sector hand in hand. Yet there were problems. Let me share. In a hospital, it was having 150 beds. During COVID, we issued, from WBCRC, we issued directions to increase the number of beds. Even the lobby, the beds were spread so that the patients cannot be refused admission. Now, one of the hospital, what happened, the medical director called me, sir, I am going to close down my shop. I was absolutely traumatized. What happened? a peculiar thing happened. The housekeeping staff of the hospital, they come from a particular area very close to the hospital, and they were infected by COVID, and 30 odd people are already admitted in the same hospital. Now, in their area, they have decided that the hospital must stop taking COVID patients, otherwise we shall not work. The entire hospital at one point of time, it was on the verge of collapse because of, not because of the doctors, scarcity of the doctor or paramedical staff, the housekeeping staff. Now the hospital tried their best to have consultations, but nothing helped. Then I was asked to what should be done. I kept my cool, and what I did in that situation, I called up the local political leader, the people representative, the councillor of that area, and I said that I am just giving you a call to just let you know that this hospital would be closed from tomorrow because of this problem. Now, unless you solve this problem, the hospital would not be run, and if the hospital is closed, the government would be in difficulty, and you belong to the ruling political party, you have to do it. It happened like a miracle, and the hospital was saved. I do not wish to name, but I want to share, because there are situations you might face even after listening to our speaker on the anticipated situations. There would be unforeseen situations, and you have to come out of that. The basic formula is keeping your cool, use your mother white, and help yourself. Thank you all.
Sir, can I please request you to kindly felicitate Professor Dr. Suresh David? Please. Sir, please be on stage. Thank you so much, Professor Dr. Suresh David and Justice Ashim Banerjee, sir. I'd like to call upon stage our next speaker, Padma Shri Dr. Subroto Das, to please deliver his special address on emergency medicine in industrial and occupational health, holding hands together. Sir.
Just give me this fine. No. Fine. Good. Good afternoon to all of you. I know we are a bit behind schedule, so I'll try to hurry. Thanks for inviting me here. Special thanks to Dr. Tirtho, Dr. Debashish, Dr. Tarafdar, and Dr. Ritro. Mission Hospital is a beacon, and I've always wanted to be here. So after the lecture, I'm going to take a trip there. It's something that I've always wanted to see. Another thanks for having me here is because it gives me a time to have puchka, chicken roll, mishti doi, and aloo chop. একটা প্রবাসী বাঙালির থেকে বেশি কি চাই is how I look at it. So thank you for inviting me here. However, there is a pain point. I'm sandwiched between two great speakers. We heard one, and the other gentleman is after me, so it's going to be a bit difficult. I'm going to take the liberty of doing a small change. Instead of emergency medicine, I'm going to call it EMS, because I come from an EMS system. I'm a doctor, but I'm look at systems. And all of you know what medicines to give, what drugs to give, what equipment to purchase. So I'm not going to go into that. I'm going to look at industrial, and I'm going to talk about our experience, the problem of the industrial emergencies, the new normal that we have, and the challenges and the way forward. This, I know it's all over perhaps, but for this generation and your generation is the defining moment. Life would be pre-COVID and post-COVID for us. And we'll have to remember that we are in a new normal, so COVID is important. Arguably the best physicist of our times, Dr. Stephen Hawking, had this lovely thing to say even before COVID struck us. And he said, life is at an ever-increasing risk of being wiped out by a disaster, which could be a nuclear war or an engineered virus. The question still is, was it engineered? Other dangers that we have not thought of, and COVID has made us realize that. The other thing COVID has made us realize is that the reason behind this gross tragedies and ill health does not come from the health system. It comes from, driven by a religion, whatever religion we are in, our cultural beliefs. A lot of people would not take vaccinations and other things, that's our cultural belief, and the politics of a nation, not particularly just about India. That is where, taking from Suresh, it's disasters happen, they're all man-made. The other thing that I learned, which is very important, and this is something that all of you should remember, that when a big event occurs in our lifetime, it gives us an opportunity for dramatic improvements in the technologies we adopt, the processes we do, and COVID was an opportunity, or is an opportunity for us to introspect, reflect back, and think what changes we can do. And that is where industrial EMS comes in. Why can I talk on industrial emergencies? You might have heard of our work that we have done on highways, the work for which I was given the Padma Shri, rescuing people, setting up systems. But as of now, we work at the intersection of 5 things. We work on EMS, we work on industrial safety, occupational health, trauma care, and road safety. We are a very rare organization to work at the intersection of 5 disciplines. Our story starts off when Sushmita and I met with this accident in 21 kilometers from home in Vadodara in Gujarat, where we stay, left to die for 4.5 hours, survived it after rescuing, 5.5 hours it took us to reach the nearest hospital, 21 kilometers from home. And Sushmita made a statement that we were lucky to be alive. Let's ensure others don't die on the highways. I always say it's good to be married, but to be married to a very adamant woman. And she said, India needs a helpline. And that is where Dr. David has been a witness to our work. And we created India's first helpline. That it was a 10-digit number then. We did not have the short codes. The short codes came in 2005. We started our work in 2002. No government help, no wallet biopsy. We had a GIS then because cell phones had not come in. GPS did not exist. And that's how we set up India's first GIS control room. That sort of became a success story, took it to 5 states. And the gentleman sitting with me there, the country is indebted to him for taking up this idea, making it a CSR, Mr. Ramalinga Raju. I always say history will judge him differently for what happened at Satyam, but the 108 is his brainchild. And I'm told that is the table that they thought of the 108, reading about us and our success stories. Our work has been studied at Harvard, it's gone to Boston, and the Tata Institute of Social Sciences. We worked in Sri Lanka, post the tsunami. Suresh talked a lot about the tsunami. I wrote a book, and we have a brand ambassador for emergency services in Sri Lanka. It's a very dark photograph. All of you who follow cricket, Sri Lanka's living legend, Murli, is the brand ambassador. Unfortunately for Suresh, me, Sanjeev working in the sector, Tirtho, we don't have a brand ambassador. And that is something this sector requires, a brand ambassador who can talk about emergencies. The industrial aspect, we have worked with the world's biggest zinc manufacturer, Hindustan Zinc, Asia's biggest private port, the Adani's biggest petroleum manufacturer, the Indian Oil Corporation, road building corporates, leading gas transmission company, GSPC, and a lot of them These are our clients that we work with on emergency sector at their sites, off their sites. We've handled 18,000 accidents in industries, ports, mines, airstrips, oil rigs, everywhere. We've even trained ISRO. And we are now starting off something which, I hope every emergency organization does. We are looking into wildlife sanctuaries. A lot of deaths happen, a lot of injuries happen. So we started to work on our wildlife. We are recognized by Government of Gujarat and Government of Rajasthan, the Director General Mines, DG Mine Safety, International Training Center of the American Heart Association, and the Petroleum and Natural Gas Board is what we are looking at. The reason for getting accredited is you can work better with authenticity. The problem. Let's come to the problem, what industrial emergencies is. The first thing I ask myself is, are we as a nation fatalistic? Are we not aware of what's going to happen to us, or it doesn't bother us? Irrespective of our religion, and it's more on industries, more on highways than hospitals. And please understand, I'm talking about something that's outside the hospital. Nothing connected to the hospital, this is absolutely outside. Safety is not an Indian priority. We all know that, and we're very proud of it. So I always question, are we fatalistic? And fatalism perhaps is a philosophy that's so well ingrained in us. We think whatever we do, it is not going to affect our immediate future. Our spiritual thoughts tell us, again irrespective of religion, that my current action does not have any effect on the immediate future. Whatever I do is what I'm forced to do. Whatever has to happen will happen. And that is where accidents, emergencies go on happening in industries. That is something that you'll have to understand if you have to handhold industries into emergency care. It's not a hospital where you're protocol driven. That is your biggest challenge. The International Labour Organization estimates that nearly 2.2 million people die every year. 270 million globally suffer non-fatal injuries. And 4% of the world's GDP goes into industrial emergencies. This is higher than the road traffic accidents, that's 3%. Jawaharlal University study said this. Only 3% of the Indian workers come from the organized workforce. Please understand that. The construction industry, the building industry, all those things are not organized. So when you're looking at these numbers, just think of the numbers. If this is just 3%, what is the other 97%? That is a very scary thing to happen. 2001, we are very slow on statistics. So this is perhaps the newest one we have. 2001, government said 30,000 crores per annum is the effect monetary loss for industrial emergencies. And they're just talking of accidents. They're not talking of cardiac arrest. They're not talking of heat strokes and other things. This is just accidents. 1/10 of the union budget of 2001 was the monetary loss in terms of industrial accidents and emergencies. The second problem, third part of the problem, the first was the fatalism, the second is what you saw the figures, is despite everything, this is the real challenge emergency physicians and EMS faces, because nowhere in the framework of our industrial documentation and everything, or the laws and regulations, emergency care does not feature. The strongest thing the World Health Organization also talks about is occupational health. The strong focus is on primary prevention of hazards. I know it is necessary, but what happens when an accident happens? What happens when an emergency happens? Nobody really has put it in the regulation framework. The ILO Convention on Occupational Health, a very major yardstick for emergencies, in essentially preventive functions, safe and healthy working environment, adaptation of the work to the capabilities of workers. These are the prime movers in occupational health as far as healthcare is concerned. Nothing and nothing on emergencies again. So that's a challenge. If you have to handle industries, make them understand this, you will come across these things. The law doesn't require it. Why should we do it? It's a very oft thing we face, right from big PSUs to the smallest of hazardous industries. As I said, the regulatory framework, the Factories Act 1948 and its amendments, the Chemical and Disaster Management, which got a greater emphasis post the Bhopal tragedy, the Environmental Act, Protection Act, which is the umbrella of all acts, never talk about emergency care. They all talk about hazards and primary care. So what has this Act translated into? Just to let you know. Disaster management plans, Suresh talked about it at length. Framing safety policies, permissible exposure to gases, and occupational health centers. Again, nothing on emergencies. So for all the industries around here, and I come from Gujarat, we have many industries around, we face the same problem. It's occupational health center. I've established it, the law requires it, I'm done with it. So if Mission Hospital here is to take it forward to the next step, hand holding is very difficult because the hand is not extended to you to hold the hand. The law doesn't want it, everyone's happy. The National Poison Center everyone's been talking about in industries, again does not talk about emergencies. So don't expect that if you call the National Poison Center, they'll tell you which antidote, where to get and everything. Doesn't work like the CDC National Poison Center that you have in US. We have been there, Sushmita and I, we know how systematically, it'll tell you exactly which shop where you can get an antidote. This National Poison Center is basically toxic surveillance and environmental health monitoring. That is what its major mandate is, and it stays the same way. Individuals within National Poison Center at the NIOH in Ahmedabad, for example, have gone ahead and created one. This place here really requires one. You're looking at a lot of hazardous industries. Mission Hospital could do with a state level poison center. The new code, I don't know how many come from industrial background or HR? Have you heard of this code? That's a revolutionary code. 2020, on 22nd of September, government, the Lok Sabha passed it. 23rd September, the Rajya Sabha passed it. 28th September, the President of India gave its assent, but it's still to be gazetted. Don't ask me why. That is how important emergency care is into occupational health. So it's a sad thing. It talks about a medical practitioner who just has to be a registered MBBS doctor in the industry. Forget being an emergency physician, forget putting up an ER, it doesn't work. And it talks, what is his duty? His duty is to examination and certification of workers, health certificates, find him fit for the job, and a medical supervision. That is all it talks of. So again, despite everything that's happened with COVID and other things, there's nothing that really has come into the framework for it. I know he's having a laugh there, but that's a tragedy. It talks of an ambulance room. So there's no ER, it just talks of an ambulance room. So our framework doesn't really talk about it. But the best part is, it, as I said, it doesn't talk of treatment, because this sentence is very important. It talks of the removal of workers to the nearest place of treatment. It doesn't talk of emergency care in industries. So if you have to drive that change, it's a long, long way off. You just remove it, take him to a place where there is treatment. So hand-holding becomes very difficult. So what's the new normal? I'll come back to that slide again. Dramatic improvements need to be done. Technologies and processes need to be in place, and this is our opportunity. So we started doing it some time back, because I'm a firm believer that what has happened in the last 5 years in emergency care in India has not happened in the last 50 years. We have ambulances everywhere. 108 is nearly everywhere. It's going to be rebranded as 112, but it's there. This is the paradigm shift that we are working on at Lifeline Foundation. We are trying to go from occupational health services to emergency medical services. That's the paradigm we are looking at. And a huge shift has to be done. And the shift has to be done by each of you here to convince an HR, convince a SHE, a health, safety and environment officer in a company and an organization, and the doctor himself to move into that place. ACEP, American College of Emergency Physicians, describes this as a new discipline in a paper. So you have occupational health this side. It's a bigger circle which talks of prevention. You have occupational medicine, which is a subset of the occupational health. And you have emergency care that side, emergency medicine, which is the treatment. This intersection is what ACEP calls as industrial medicine. So a cross-section of EMS and occupational medicine is the new dictum, industrial medicine. So we need to coin that term here and take it forward to make people understand that this is industrial medicine. We did 2 conferences back to back, 2018 It was the first attempt ever in the world to have a national industrial EMS conference in Ahmedabad. We followed up in 2020, the day Mr. Donald Trump, the former POTUS, landed in Ahmedabad and created chaos with security and everything, but we still had a good conference with 400 people. We are going to repeat this in 2024. I'll share the brochure with you here. A familiar face would be Dr. Tomurish Kole there. Yeah, there he is. I suppose many of you must have seen him here. The last part of it, challenges and the way forward. This is simply what EMS is all about. All of you know that. There is no second thoughts about it. The triage, treatment, transportation, and tertiary care facilities is what makes EMS. Whether it's a golden hour, the platinum 15 minutes, an universal access number, every industry should have it, efficient transportation and communication, and upgrading of first aid centers and ambulances. But the key to it, I think, is training and awareness. Having said this, there's four things, T's. It's very easy to do in a hospital. Triaging in a hospital is very easy, believe me. Even in a highway road traffic accident, it is easy. But it's not so easy when it comes into an industry. Because industry, HR people, industrial officials will tell you, there is something called IR issues at the bottom. Industrial relation issues. If you had 2 emergency physicians and 10 paramedics triaging 10 people within the enclosure of an industry, that is a disaster. Because you're creating industrial relations problem. The union will come in, the workers will come in. Kaise mare ye? So the first thing that happens in an industry, please understand, despite all good intent of the management, is patient ko yahan se jaldi nikalo. Get the patient out of the security area, the battery area or whatever you call it, because they don't want 20 other people coming there and then making hue and cry and beating up the HR guy perhaps, for all you know. So triage really does not happen in industries. Do not expect magic here. You might think I'm playing the devil's advocate. You have invited a devil's advocate. No, that's not the story. I'm just giving you reality. The other issue is you have to understand, no 2 emergencies are same. Even in a hospital, they're not same. But industry more so, because no 2 incidents are same and no 2 industries are same. That is a challenge you have to remember. An emergency room or pre-hospital care service is SOP driven, or it should be at least. But in an industry, you don't have SOPs for emergencies because they're all different. So when we work with Hindustan Zinc and somebody's fallen into a sulfur dioxide tank, which is very different from an L&T IDPL, which is into infrastructure. So because the industries are different, the protocols are different, it becomes very difficult for emergency management to work that way. So if you look at a typical OHC, Occupational Health Center, you are very lucky. Dr. David talked about coordination, hand-holding. Imagine this OHC officer here, this doctor has to do so many things. He is to be talking to the OHC in charge, the ambulance, the industrial facility, the mutual aid system in that district, the district health officer if a disaster happens, the collector and the DDO will call up asking for information, the police department will come in because it's a police case, and the other medical centers will jump in trying to take the patient away. So it's a very complex thing, and then you think he's going to do emergency care for you? You really have to believe in yourself. So doing this part, the industrial medicine is a challenge. It is a question of huge things, just not changing the doctor. It's changing their entire industrial environment. It's HR thinking, it's health, safety, and environment thinking. Ambulances. Frankly speaking, I've come to realize ambulances is not the magical cure. I don't even know what government means or politicians mean when they say golden hour. For them, golden hour is reaching first aid. 2 emergency physicians, brilliant ones, Dr. David and Dr. Bhoi will say, it is onto the operation table. That is what you need to achieve in the golden hour. In industries, they think they've got an ALS ambulance, they've got a ventilator, they've got a monitor, but they don't have a trained doctor or a trained paramedic. Industries think, because every worker thinks, ambulance aa gaya hai, it's a magical cure. My life will be saved. A false sense of security comes in. So when you start working with industries, the first thing perhaps that HR fellow or the commercial fellow will say, एक advanced life support ambulance का quotation कितना होगा? Specifications कितना होगा? It goes nowhere. Frankly speaking, I have not come across a term anywhere. I think both of them will agree. ICU on wheels. It's a very Indian concept. Kahin nahi hai. And Sushmita and I always share this thing. We were in Singapore, one of our first trips. I'm part of founding chair of the Asian EMS Council. And we went to this place and ordered for Singapore rice. We eat it very well here in India. This lady looked at us in amazement and said, "You're from India?" I says, "Why? How do you know that?" Because Singapore rice is only available in India. It's the same. it's the same way. ICU ambulance is an Indian concept. And I'm sure you can't even put a capnograph and measure oxygen saturation because it goes on moving. It's as simple as that. But every industry will ask for an ALS ambulance. And so how do you rework this? All of you follow cricket? Most of you do, I'm sure. Take a fresh guard. After you've hit 100 or a 50, take a fresh guard. That's what you have to do when you start working with industries. And you'll have to bring the top management in, not the doctor. A medical doctor in industry has various stages of reporting. In fact, there are times they even report to the security officer. It's sad, but the security officer is the administrator there. So you'll have to go to the top management to convince them. But more importantly, you'll have to have a buy-in from the workers. Workers need to understand how to access EMS, when to access it. Only then it works out. Otherwise, it will never. You go into EMS, there has to be a special consideration, I feel, for industrial staff and this category of people: safety, OHC, EMS, ambulance crew, firefighters. You need to look at something called PTSD. All of you are aware of PTSD. We all face PTSD. I'm sure COVID has aggravated it. We had harrowing experiences. But industrial people in safety, health, environment and medical have a very strange thing that happens. And I'll tell you why. If you lose a patient here, the patient's relatives will get angry perhaps. If you have goofed up, your bosses will get angry, or clinical bosses will get angry. But in industry, something else happens, and that's very important. You are blamed by the co-workers for losing a co-worker. You are the emergency physician, doctor in an industry, and you have lost a colleague with whom you had to sit and have lunch every day, had a fall from height, came to you, you could not save him. The entire workforce perhaps will go against you. You become stigmatic. They start shunning you. So emergency care in an industry is not that easy. That's why doctors will say, "Jaldi leke jao na, mere pe blame nahi aaye." So that's a challenge you have developing and handholding emergency services. Training, and we were invited at KBC to talk about, that's our son demonstrating to Mr. Bachchan what CPR is. We thought we would get a brand ambassador. It did not happen. That's Tapsi Pannu beside me. But that just did not happen. They talked good. That was all. But training and awareness is very important. But when you look at industries, there's difference in training. Chemical spillages, red zones or hot zones, antidote usages, airway protection, spine stabilization, PPs, they come very important. So medicines, crash carts, ambulances, umbo bags, everything is fine, but you need to look at these things in particular when you're looking at training in industries. It's a very different ball game. We started something called Vadodara Smart City or CPR City, a city of 2 million, like Durgapur, and I would request the Mission Hospital to look at it. We trained 25,000 industrial workers across Vadodara to sensitize them that you need to make a difference. Because if the workers and their unions drive it, there's nothing better for emergency services in industries. This is the conference I was talking about. It's called NIMS 2024. It's the 3rd edition in Ahmedabad, 16th to 18th. And if you're looking at developing industrial medicine, you need to be there. So that's what it is. And there's workshops on industrial burns, industrial disaster life support, industrial toxicology, trauma, all industries that we're talking about. It's the only one of its kind across Asia, I'm sure. Thank you once again for having me here. I hope I have not exceeded my time. Thank you. Sure.
Thank you so much, Mr. Brutadas, sir. May I please request Professor Dr. Makhonlal Shah, sir, to felicitate Dr. Subratadas, sir. For this speech. Thank you. There has been a slight change in the program. May I now request Professor Dr. Sanjeev Boyser, Professor, Department of Emergency Medicine, AIIMS, New Delhi, to kindly deliver his special address on development of integrated emergency care system.
I thank the organizers for inviting me for giving this lecture on developing an integrated emergency care system in our country. So while the PowerPoint presentation is going to be on, just thank all the organizers, especially the director, sir, of Mission Hospital. And really it is a privilege to speak in the Mission Hospital, because right from childhood we know the good work being done in Mission Hospital across India. And so one of my own student is also here, Dr. Soumitra, so I'd love to back here to city of Durgapur. I was here last year, I think last 2 years back, for an inspection of the DNB, inspection of a hospital. So why at all this topic of developing an integrated emergency care system? So let me take you, let me take you to a usual, incident which happens in everybody's family, and we'll see the landscape of emergency care across the country through a patient. So let me take you, it's the early morning hours. I was sleeping in my other room, and suddenly I heard somebody falling down. It's my grandpa who fell down. He complained of chest pain, he had some dizziness and fell down, and he has broken his leg. And also I am suspecting that has he developed an acute coronary event, early morning hours. And it is not dissimilar to all the events which is there in households. So the key question is that where shall I take him? Shall I take him to a trauma center because he has broken a leg, or probably he has a sustained injury? Or shall I take him to a cardiac center, which also has, he may be having require a definitive acute coronary intervention? So this is a jinx I am having right now, seeing the system. So next question is where, how shall I take him at early morning hour, whom to call? And during the transport, do I get appropriate care during the transport? Once I reach the emergency, will I encounter a trained emergency doctor who can take care of my grandpa? And what happens in early morning hours? You don't have cash. How do I take care of, even I have a rich, well-to-do family, how do I take care of out-of-pocket expenses? So these are the questions you need to, while I am asking, and let us understand how in the whole country, how it addressing it across the country right now. So if you see, the burden of emergency conditions is humongous. The landscape of emergency burden is communicable disease and non-communicable disease. If you see the gray ones, it is a 62% of non-communicable disease, which is playing a part of emergency conditions, reaching to the casualty of casualty across the country. If you see the ICMR report 2017, earlier if you do the top-notch top 10 conditions, if you rank from the top one was neonatal emergencies coming to the emergency department. And if you see that respiratory disease, diarrheal disease, ischemic heart disease, tuberculosis were the first 5 top-notch conditions which presents to the emergency department. And it is after a decade, 2007 and 17 ranking, neonatal emergencies are still the highest. And other non-communicable diseases are still highest. You see the trauma, it is down at 9th number. Burden of emergency conditions. You can understand which are the top-notch killers in the emergency department. So this is our own study. If you see, there's the huge burden of both emergency and trauma condition. Why you see that only 15 to 20% is only trauma. almost 80% in non-trauma emergency coming to the emergency departments. This is a study conducted by us, funded by Niti Aayog, when 2018 they called a meeting to develop world-class, how can we develop a world-class emergency and trauma care system in our country, envisioning. They were called and they had to give a speech on that, a 10 minutes presentation to the Niti Aayog with all the stakeholders who were there across the country who is dealing with this sector. They were actually reassessing what has gone wrong, because there was a, definite 10 years of intense investment in trauma care. Whether it is care governance level, funding, everything you need. And despite that, why the fatality has increased from 16.6 to 22.4. So this is the one-day study which we did in 100 facilities across the length and breadth of the country. Some of my own students who are sitting here has participated in this study. Both right from the north to Kerala to the northeast to Gujarat, including the center in a one-day flash mob study, both adult and pediatric. You see the trauma burden. You see here it is 24% in adults. In pediatric, it was 9%. So 9 to 24 among 100 facilities. And the study, the AIM study which we focused, it assessed the gap assessment. What are the current gaps in terms of trained human resource, equipments, supplies, okay? So what is the current status of emergency department in both 50 tertiary care medical college level, more than 300 bedded, less than 300 bedded, including both government and private, hospitals, nursing homes, as well as district hospitals also were assessed. So you can just see the statement here of a poor quality, both, emergency care delivery, as well as both at the pre-hospital care level, pre-hospital care level, and also in the emergency care facility. So there are gaps and barriers were identified. So that's why, that means there is a poor emergency care system existing in the country, which both highlighted the pre-hospital care and emergency care. Dr. Subrata was speaking before me regarding the EMS system. So you can see the, the flash mob study which was done across again, it tells you that. So that's why, if you see, why do we really focus on this emergency and trauma care services? This is because, if you see the death and disability due to emergency care condition which includes trauma, the premature death and disability can be prevented by establishing a strong emergency care system. So what do you mean by this system? Emergency room, you see, suppose my grandpa, when you're going to the emergency room, it is a single patient. So I need to phone up somebody, oh, take care of my grandpa. By creating a system, it is independent of individuals. Whoever it is there in the emergency room, if they are trained, they can take care of my grandpa irregular of who is there in the shift. That is called as creating a system. So individual approach and creating a system. In system you create, you are saving a lot of lives rather than a single life, standard of care. But right now, both emergency condition and trauma, if you see, it is right now a divided house. Some 10-15 years back, there were a lot of initiative in trauma care because it affects the young people, 15 to 45, and it costs the government 3% of the GDP. That's why there are a lot of investment. Almost 700 trauma centers were built over a decade and a half. For 15% of patients coming to the emergency room, 85% are non-trauma emergencies which flock to the emergency, which was actually, as I said, they never looked into that. Because another thing is, it gives a lot of visibility. If you take care of trauma, oh, I built trauma center, let's build a trauma center. It becomes a political tool as well. That, oh, just like running a train in Bihar, suppose I come from there, everybody was fancied, let's have a train to my village. Similarly, let's have a trauma center everywhere. Or let's have a AIMS, where my institution, CRUM, everywhere if you see, there are multiple aims are being built. So this is what, skewed approach of, was there in that time. So the government of India again relooked in 2018 in that lecture. This slide was there in my lecture. So then I propose, then we say that before the trauma thing came, the same emergency were being managed by in the same casualty, the so-called casualty, which the transformational journey was happening from casualty to emergency medicine, by many luminaries and some of them sitting here, and you're talking about system, creating a system over 2 decades, 3 decades, multiple voices. WHO came up during that time in a model of an integrated approach of emergency care. I mean, all kind of emergencies should be, dealt in the same emergency room, in the same health facility which can manage both trauma and non-trauma. At the smaller hospital level, mid-hospital, that is primary care, secondary care, tertiary care, and you can have apex centers across the country for providing leadership, because it's a huge country, north, south, east, west. Rather than having separate buildings of trauma care facility, separate human resources required, separate funding is required, everything you have to replicate, and for God's sake, you are not getting people around. You don't have people around. And many of the trauma centers across the country, they are lying idle. Equipment and supply are lying idle. So which we could have utilized for integrated system, which is more holistic. Even in US, they are closing it. They are amalgamating with the same facility. So it should be trauma care, best trauma care rather than trauma center. Care delivery is more important, ladies and gentlemen, rather than center, creating empires. So that's why we created a tree, the WHO integrated model, strategic directions for integrating emergency and trauma care in the primary care setting, at tertiary care, but having an apex center separately. All kinds of systems are feeding into this tree, you can see this. And follow the WHO system framework model. This is what I am saying is integration. Right at the scene, suppose somebody develops a road crash, or suppose develops a chest pain and falls on the ground or in the house. At scene, en route in the ambulance, and reaching the emergency department, and then going to the definitive care facility, which is called critical care, or going to operating room providing acute care surgery or trauma. And again, the fourth chain is rehabilitation and going back to the community, going back to his home safely, just like my grandpa after so going back to my own house. So here this question, this figure answers the question which I had at 4 a.m. Where shall I take this patient, my grandpa? I should go to a facility which gives you all types of care. I can't have a MI for some and trauma, broken leg for some. That is the answer. So as a community, what shall I do? I should give something, recognize, remember, recognize the sick condition. Give basic first aid, resuscitation. And third is referral to the appropriate facility. 3R concept. Recognize, resuscitate, refer. Simple. By this, you can reduce mortality almost 50-60% of premature deaths you can, just by improving pre-hospital care and emergency care. So the envisioning, this is envisioning, because I also serve as a technical advice to the Niti Aayog after that study, along with Professor Vinod Paul, who is also member Niti Aayog. So this is the envisioning of the Planning Commission, not my statement, but this is envisioning of the Planning Commission. See this slide. I took some of the slides from that presentation. So we need to develop a robust system that delivers timely, optimal emergency care at the right place with the right skill from the first time, ensuring seamless continuum of quality, which is accessible, affordable, equitable. It is for all society, all parts, all this thing, respect to out of pocket, distributed to all citizens of the nation. This is not my definition, this is envisioning by our Planning Commission or Niti Aayog. So let's see what is the envisioning is. You should have an integrated emergency care model rather than systems in silos. Keep on building trauma centers. No, you have a separate facility. So I'll give you an example where it is being practiced right now. After we had discussion with Tamil Nadu government, they visited at our place and we had a discussion along with Planning Commission that they created what is called as the TAI, Tamil Nadu Accident and Emergency Initiative. They created a policy, first state to create a such policy of an integrated approach. They had 6 bundles of care. They included trauma, stroke, STEMI, burns, maternal child health emergencies, poisoning. So they took a bundle approach. If you focus this much also, reduce the mortality, reduce the time-delayed access to care, the emergency, this is the killer, common killers on the emergency room. Suddenly the population will benefit. And it addresses the sustainable development goal of WHO. See what has happened. It has reduced trauma mortality. See, this is 8 months data. I've taken this slide from Dr. Marutu, who is the mission director of TAI, thanks to him. So he has shown that the reduction of trauma mortality, you see that by almost 50%. See, that is one of the goals of sustainable development. And similarly there is a decreasing trend of mortality in non-trauma emergencies. See, this bundled approach, unifying approach is the key. They worked on right from pre-hospital care to the emergency care to definitive care, in a system. Morning, there was some discussion, confusion, what is critical care and emergency care. So in emergency care, you see a lot of patients in short time. Uncontrolled environment, patient of sneezing to cardiac arrest will come, neonate to prostate, sneezing to cardiac arrest. And it's a dynamic thing. In critical care, you see the same 12 or 15 or 20 patients for the next 15 days. That is high intense and you are giving all time. So that is the difference of control environment, non-control. So, but they are a part of acute care system, continuum of care. So this is an integrated model, the top 6 they have taken. They have created IT-enabled pre-hospital care. IT-enabled. And 108, Dr. Subrata has already spoken about it. I will not skip these slides for brevity and interest of time. This is the building blocks of a strong IT-enabled pre-hospital care. And we are going to be a 6G nation. We should see that, the best this thing. But add signs of pre-hospital care into it. Right now we are only giving service delivery. The next envisioning is create academic programs in EMT. Basic, intermediate, advanced, bring research into it. So that is the envisioning right now is happening in Government of India. There are 2 slides were dedicated to that. TAI has done great work. The response time is less than 9 minutes. I am sure most of the states are doing. And create, bringing, thrombolysis in primary care to the STEMI, thrombolysis of stroke in the ambulance. This is another envisioning is happening at the ICMR as well as at the Planning Commission level in a hub and spoke model. Few of the states are already doing it. Goa, they are doing it. They are a part of the hub and spoke model. Save Kashmir or Save Heart Kashmir. They are doing it. Private, doctors are they are doing, across length and breadth of Kashmir. Save Heart Kashmir. Just look into this. Excellent. Some of the work is happening. So this is the grid and density, accessibility of pre-hospital care should be there. Nationwide uniform protocols. This is one of the TAI protocols, but please go back. We have during this COVID, we worked on operational guidelines of standardized emergency care in primary care setting, in secondary care setting. These have been now, published by Government of India, operational guidelines, because there will be also funding towards it. There is investment, funding towards operationalizing these guidelines in primary care and secondary care. Next thing they worked in Tamil Nadu was, this is what, not Tamil Nadu, that was a model of integrated emergency care. So it is happening in other states are picking up. Rajasthan is going to have RAI project, Rajasthan Accident and Emergency Initiative. Now Assam is picking up. Right now, UP government, we are now doing the envisioning and system building in UP in 33 medical colleges of UP. Right now we are doing with Satat Sanjeevani project. Recently to establish emergency doctors. So now we have gone into emergency room. Emergency room across the country right now, we know that last 20 years of work has been done and we established emergency medicine in 2009. Okay, there is a fast tracking of emergency medicine. The national policy says that you should have trained emergency medicine specialist, emergency nursing specialist, emergency medical technician specialist. So this is already there in planning commission policy. And NMC also gave that mandatory requirement minimum standard 2019 after that deliberations by Niti Aayog. Revolutionary step that fast tracked the emergency medicine seats from 100 to 400 by 2023. But of late there is some error or aberration of recent, this thing I am not going to speak about, but people are in talks to reverse that or reinstate the previous thing that is going on. That's not a big, it's just a roadblock, or you can say just an aberration in the journey of transformative journey which the country is envisioning. So during this time you can see that there is an amendment of Good Samaritan guidelines. It is only related to trauma. It is not a law, except Karnataka, which has really made it as a law in Karnataka. But it has to be for all conditions, not only for trauma. So last slide is at 4 a.m. when I took my grandpa, how to get money, where do I have cash to pay the bills? So this is what is called out-of-pocket expenses. It requires cost. And there is also a debate following the lunch, I think there is a debate on cost cutting, does it affect emergency care? Here there is a 48-hour cashless care for emergency treatment. This is for all citizens of India. This is envisioning. Already few states, if you see this slide, already few states are already doing it for trauma. 48-hour cashless. That means the insurance payment is paying for the patient's bill. Patient can go to any empaneled private hospital or the government hospital, and the bill will be paid by the state government. Rajasthan, the first experiment happened with Asian Development Bank in the corridors of Delhi-Jaipur highway, and they gave first that. So that initiative, now they escalated to other states like Rajasthan, Gujarat, Tamil Nadu. In Delhi, they give for any amount, they can bill up to 70 lakhs. They can, bill can be given, and they can be, in Delhi there is no 48 hour. In Delhi they can, till they are discharged, the whole bill is paid by the our Delhi government, Kejriwal. So this is the thing is, so I'll just leave you some thoughts is, the whole focus over the years was only predominantly trauma centric. If you see, all the plans were trauma centric for 15-20% of patients. So the thought process changed of having an integrated system in the government level in 2018 onwards. Strong focus, what we can do is quickly envisioning means already the trauma centers are built. Now you can't reverse it. What the low-hanging fruit is, easy things to do is convert, you take all kind of emergencies there. Make it as the acute care center, both ER, common ER. Have separate trauma wards, polytrauma wards, okay, give them in that facility. Or in the medical college, existing medical college, they should give both, rather than naming something a trauma. If some deficiencies are there, you fulfill that, take the money from that. So convert into a trauma plus emergency care. And second is invest more from the beginning only, you name it as an integrated emergency and trauma care facilities. That will save us money as a government. Same human resource will be dealing with trauma and non-trauma. Remember, if you only do trauma throughout your life, you will be traumatized, as a clinician. Isn't it? I can't do 24/7 around throughout the years. Where is my exposure to non-trauma? So this is the landscape, current overarching landscape of emergency condition. Is various programs are going on in the Ministry of Health. These also programs need to integrate at the ministry level. That is what government is working on, to integrate. There many fundings are parked in different heads of program. Money is available in different heads, working for the same cause. Okay, so they are also saying that integrate the programs, integrate the pool of money, for integrated emergency. And third, have one lead agency for emergency care delivery system in the country, which includes pre-hospital care, and includes in-hospital care, and includes critical care. And rehab is a strong component so that patient grandpa can go home. So in summary, the gaps and barriers need to be identified locally within the hospital, within the city, make a network of both pre-hospital care and emergency care. Build a city-wide. Durgapur should have an emergency care network. Build in robust integrated emergency care system as a city level, state level, district level, and national level. Right now we are working in district level in 10 districts of India as a ICMR project. Right now we are going to do, I am got the grant for it. 5 district, 10 district we have got across the country to build a model. What works at PHC level, what works at CHC level, what works at district hospital level, what works at medical college level, what and how they should be integrated by 108 or pre-hospital care level, and how community participation can happen, awareness, back to the community. So with this, let me close my talk and saying that, remember, system saves more lives rather than individualistic approach. Thank you very much for listening to me. I think I finished in time.
May I please request Dr. Maitri Banerjee ma'am to kindly come on stage and felicitate Professor Dr. Sanjeev Bhoi sir. Thank you, sir. Thank you, ma'am. Next, we have another simulation study on cardiac arrest to be presented by Sister Saraswati Roy, Chief Nursing Superintendent, the Mission Hospital, along with her nursing team. Sister Saraswati.
Good afternoon, everyone. I am Sister Saraswati, the Chief Nursing Superintendent of the Mission Hospital, Durgapur, and a BLS and ACLS instructor too. I am really very overwhelmed and privileged to be a part of this conference. So I wish to thank the organizers. Thank you, ma'am. Thank you, sir. And I was asked to speak about code blue scenarios, how it is dealt in our hospital, and a bit about cardiopulmonary resuscitation, or CPR. CPR, as we all know, is a technique of basic life support which is given for the purpose of oxygenating the heart, lungs and brain until appropriate medical help is available to support the ventilatory and circulatory perfusion. And for this, one of the emergency code has been devised. It is running since years together all over the world, and it is called Code Blue. In our time, there was no code or team for prevention strategy, but now it has come up, and that is called as rapid response teams. So first we try to categorize our patient according to RRT score, but sometimes it is very difficult and patient go into cardiac arrest or cardiopulmonary arrest, which is the sudden cessation of heart and lungs function. The case presentation to us will be, the patient will be unresponsive or deteriorating down to unresponsive condition. There will be absence of major pulses and there will be no breathing. So let us first go through the video of the early thing that we do, that is BLS. So I will take you to a short journey to our daycare ward, where the patient has got admitted for daycare coronary angiography, as most of our daycare coronary angiography are Sastosati patients. So we will see how a 55 years old woman, she got admitted for coronary angiography, went to washroom after her dress change and all, felt giddiness and breathless. The nurses, they helped her to the bed. Initially, she was showing bradycardia type of symptoms. It was symptomatic bradycardia, oxygen provided, and before we can proceed further, she collapsed and became unresponsive. So please kindly be with me and view the video. Lights. This is a patient who is 55 years old, came for... She gave the call from the washroom. Sister came to help her.
रुकिए एक मिनट रुकिए सिलचा एक जन आ जाओ ना पेशेंट को कुछ प्रॉब्लम हो रहा है कष्ट हो रहा है आ जाइए तो बहुत घबराहट हो रहा है क्या हुआ
She's been helped to a bed.
बरनाली दीदी आ जाइए ना थोड़ा जल्दी अरे अब भी हो जाएगा
Her vitals assessed. The blood pressure was very low with a low heart rate. And she was breathless, so it is symptomatic bradycardia.
Mrs. Berman, आपका घर से कोई आया है? कौन आया है? बेटा है? ठीक है बेटा बुलाएगा ठीक है
Sajida, safety was verified. She was slowly desaturating and collapsed.
Mrs. Parwan,
Activate code blue, bring a tax value in
response नहीं कर रहे
They checked for response, activated the response, emergency response system, assessed pulse and respiration simultaneously,
4, 5, 6, 7
and then started high quality CPR. At a rate of 120 beats per minute, depth of, as she's an adult, so 5 to 6 centimeters, and in a ratio of 13:2. So this was the first part which shows the BLS survey and the links there. That is the first, the immediate recognition and activation of the emergency response system, early CPR, more emphasis is on chest compression. For any cause, we should not delay the chest compressions. And the third is rapid defibrillation. As soon as your defibrillator or AED device is available. Because we have seen studies which shows that only CPR or delayed defibrillation shows very less survival rate, and then with rapid defibrillation and high quality CPR. Now we will see the next part of the scenario when they have activated the team and the team arrives. So what happens, that we have to see. So Code Blue team arrives. So the ward team, they were continuing with the CPR and defib was getting attached by the time the code blue team has arrived.
What happened, sister? Okay. Okay, our team will take care of the scenario. Brother Sarun, you take care of the part of compression along with Sister Sajida. Brother Pradeep, you take care of ventilation and airway along with Sister Silja. Sister Vidya, you take care of IVSS and drugs. Brother Bins, you take care of the part of monitor and the defibrillator. Sister Ankana will be our CPR coach and you will be the time recorder also. Sister Bernali, please make arrangement for ICU bed for the patient. Brother Bins, I can see a disorganized rhythm on the monitor, so you should be ready with the 200 joule of asynchronous biphasic shock. When we get ready, please inform me. Sister Vidya, please check the IVSS. And take one ABG also.
Sarun, please allow the chest to recoil.
Okay, shock is ready. Stay clear. I am giving biphasic lesson in my 200 shock.
Resume CPR. Sister Vidya, be ready with 1 milligram of injection epinephrine plus 20 ml of flush.
Injection 1 milligram, epinephrine 20 ml.
Yes.
Over. Can we switch role, analyze rhythm and check pulse? There is no pulse. Start CPR.
Brother Bins, still it is VF, so you should be ready with another shock of 200 joule of asynchronous biphasic shock. You ready?
Shock is ready. I am ready to shock. Stay clear. I am giving biphasic lesson in my 200 shock.
Resume CPR. Sister Vidya, please administer injection epinephrine 1 milligram plus 20 ml flush.
Sister Sajda, we have to achieve the 120 beats per rate. Injection epinephrine 1 milligram over with 20 plus.
Sister Silja, are you feeling any resistance in airway? Yes, sir, I feel some resistance. Okay, Brother Pradeep, you can go with advanced airway. Sister Vidya, please administer one more injection epinephrine, 1 milligram plus 20 ml flush.
Excuse me, so injection epinephrine has to be repeated after 3 to 5 minutes.
Exactly, exactly. Thank you for your correction. Sister Vidya, Brother Pradeep, you achieved the airway, no? Okay, so then you can give one breath in every 5 to 6 seconds. Sister Vidya, make ready with the injection aminoderone 300 mg plus 20 ml flush. Yes.
2 minutes over, switch role, analyze rhythm, check pulse.
Space there.
Stop
Okay.
CPR.
Okay, I think, see, I think I can see organized rhythm on the monitor. I think we achieved ROC. So we can again start with the primary survey. So let us start with airway. Airway is patent, no brother? Okay, what about breathing? Okay, so start capnography. Brother Beans, please check the vitals. Okay, so we can think about the reversible causes, 5H and 5T. So what will be the probable cause for this one?
Sir, I think it is due to hypoxia.
Exactly.
Sir, I think it may be due to toxin or allergies.
Okay.
It may be hypovolemia.
Okay, sister, please start IV fluid also.
Patient is admitted for CAG and it is a case of hypertension and diabetes.
Yes, exactly.
Think about coronary thrombosis.
Yes, sister, it may be the possible cause. So, Brother Beans, please take totally DCG. So, someone please arrange. Okay, okay, sister, thank you.
Sir, ECG done, sir, I think it is properly STEMI.
Oh, yes, exactly. Sister Bernali, please activate code STEMI and inform cath lab also. We can shift the patient immediately to the cath lab. Lift is ready, no? So we can shift.
After shifting the patient to cath lab by activating code STEMI, then comes the debriefing session. That what was good points and what were the gaps that we can improve next time. So our team leader will be debriefing with the team.
Thank you all. Our code blue scenario we conducted very well. So first of all, I want to tell about the positive points. Our ward team members, they activate the code, and our team reached within 2 minutes. So according to our organization policy, we should reach within 2 minutes. That is a good part. And they initiate the primary chest compression immediately after analyzing the scenario. And mainly about our monitoring and defibrillation part, Brother Bin's done a great job. You assess the rhythm and you even defibrillator on time, and it was very good. So that's why after 2 shock, we achieved the ROC. So I think patient will recover soon. And about the airway side, Brother Pradeep, you easily put the advanced airway. So that is a very nice part. So that's also appreciable. Then about our CPR coach, sister, in between I also tell about the one mistake regarding the injection epinephrine. You corrected me, so that is very good sense of team dynamics. And regarding our compression part, so I know it's a very tough part. Then also we want to improve our compression through proper practice and all. So these are the positive things. So very little negative part, we done very good, great job. So thank you everyone.
So what we have seen is for any successful resuscitation, we need a team, and there should be a very good team dynamics. Team dynamics, there are many factors to it, but the most important 2-3 factors which I have learned over the years is that whenever we are giving roles and responsibilities to our team members, that should be very clear and that should be within their limitations. If somebody is not aware of defibrillation, we should not appoint them that you defibrillate. So this should be very clear to team members that what that member can do, and that has been assigned to him or her. Then comes that there should be mutual respect. Why I don't say that we don't give respect, but in an emergency situation, panic occurs and that leads to all shouts and chaotic situations. But all these chaotic situations can be covered up if we give clear roles and responsibilities. We have clarity of our orders, whatever is given, that what to do. If I say you have to start infusion dopamine at a max of 5 to 10 or 5 to 20, what is mentioned in the algorithm, then it becomes confusing. If I say that please start a dopamine infusion at a max of 6 max per kg per minute, it is a very clear order. So this type of thing should be clearly mentioned. And then we should invite everyone to give any, what is their idea about the thing. Like we asked that what can be the probable thing in this patient, why this patient went into cardiac arrest. So we should involve everyone in the team, and there should be constructive interventions. So we at Mission Hospital, we not only follow the chain of survival, let it be adult or let it be pediatric, which starts with rapid identification, activation of EMS, early CPR, then rapid defibrillation, then advanced life support, and integrated post-cardiac arrest care. But we also work on team dynamics, because it does matters. Because if it is not maintained properly, we may have to lose the life of the patient, and that is not done. So emergency codes has to be practiced and practiced again and again, and there comes the role of mock drills. So that one small mock drill portion, we have tried to show it to the learned audience, and likewise we learn every day. Thank you so much.
Thank you so much, Sister Saraswati and the entire nursing team, for a wonderful presentation staging the simulation study. May I please request Professor Dr. Suresh David sir to kindly come on stage and felicitate our nursing team headed by Sister Saraswati.
Sister Saraswati and the nursing team, I must compliment each and every one of you.
Thank you, sir.
You have done an excellent job, and the clarity and lack of confusion, and each one knowing your roles and responsibilities is indeed commendable. So wish you all the very best.
Thank you, sir. Thank you so much.
And I know that, if I have a cardiac problem and if I come to you, I know that you will take care of me well.
We pray. Thank you, sir. Thank you so much. Go there. He's our nurse educator. You come forward. Come forward. This is for you all. Yes.
Yes.
Yes. Yes. Hold it. Bajrangbali style. Yes.
Individual mementos would be sent to the department.
Thank you, sir. Thank you so much.
Since we have already passed the lunch time and I'm sure everybody is very hungry, we have a little change in the program. We would break for lunch now. We will gather here back at around 2:50 to convene our post-lunch session. Thank you so much.